All right. All right, so I'll let you guys ponder this meme here. I have tons of these little memes. Um, so you had to have watched the, EKG and antiarrhythmics video. Yes. Okay, so Corbin Blue. Yes. And so what is he on? And again, I'll give you a hint, it's a heart block. Yes. Amazing. So it's a Corbin Blue on a Mobitz too. So nerdy. I know. So there's like this meme thing, and it's like you've heard of Elf on a Shelf, but have you heard of? And then it's just things that rhyme. I have a lot of these, which I'll put in future ones. Yeah, you may leave. I give you guys permission to leave for putting this on here. Um, yes, what is your question? Unless you're just raising a hand for fun. Oh, okay. All right. Um, Yeah, so this is Corbin Blue on a Mobitz 2. Oh, I see. All right, bye. So Corbin Blue on a Mobitz 2. Remember Mobitz type 2, so your second degree heart block. There's type 1 and type 2. Type 1 is Wenckebach. That is going to be where the PR intervals progressively get longer, and then you have a drop beat. Type 2, so Mobitz type 2, so second degree heart block type 2 is where the PR intervals are the same, and then all of a sudden you drop a beat. So that's Corbin Blue on a Mobitz 2. All right, glad we got that out of the way. All right, so very quick reminder, because I keep hearing things pop up. Just a reminder, I don't have anything to do with the exams. I know I sub as facilitator, like here and there, but whenever I'm like, oh, like this is really important, this is something you should focus on, this is like from my experience with what was emphasized on both sets of boards, with my old PBL classmates who are currently in fourth year C and what comes up and what they get pimped on. That's what I try to tell you what to focus on, but I have nothing to do with the exams. If I facilitated for you guys before, I always give stories that like my first year PBL exams had stuff from future blocks on it a lot of the time. So like they can literally ask anything and that's like they're allowed. That's the point. So it's kind of like the syllabus is good. It's a really good starting point, but also use like the cases to guide your learning. Like when things just pop up, that's what's cool about PBL. When like things pop up in cases, LIs, you have time. Like you don't have weekly quizzes. Like you have time to kind of sit there and like learn about it, something that you find interesting. So I'm just gonna like remind you guys about this, just to remind. Like if I say something's important, I have no idea what it's gonna be on your exams. Okay. All right. So here are the objectives. So here's what I'm covering today. We're going to do a little bit of everything. Like I said, it's a lot of path. So I'm going to be starting with cardio, and I call it the itises because we're going to be focusing on endocarditis, pericarditis, myocarditis, going through some rheumatic fever, and then switch to some renal stuff at the end. So like kidney failure, again, when I say it's like what's on the syllabus, you guys have like a week until your exam. You're not going to learn everything about kidney failure right now. Like if you haven't even touched kidney failure, like this is at least the bare minimum of what you should know. You're going to go into a lot of depth second year. Micturition, so like the urinary reflex, that's very neuronal, and I do go into it a little bit, but you will cover it a little bit more for like during neuroblock. But to understand incontinence, you need to understand what happens with all of these nerves that activate micturition. And then your kidney stones, kidney infections, cystitis, some pyelonephritis, and then going into some lipids, so like atherosclerosis as well as hyperlipidemia. You technically cover hyperlipidemia next block in GI block. But I'll still give you it's on your syllabus for sure. So I will still go into it. Not saying it can't be on your exam because again, anything can be on your exams, but I'm just saying like you're a week out. This is at least the bare minimum of stuff. And then some questions. Okay. And as per usual, since I'm recording, if you guys ask me a question, I'm probably just gonna repeat it just for the recording. So it's not like I'm like trying to sound it out. But okay, so starting with cardio, again, I went straight to your guys' syllabus in terms of what to focus on. So your endocarditis, acute pericarditis, myocarditis, and then rheumatic fever. All right, so endocarditis and rheumatic fever, these are technically considered valve disorders caused by some sort of lesion. They can be vegetations, they can just be destruction, immune complexes, but it's going to cause a valve disorder. And then valvular lesions generally either result in stenosis or regurgitation. And that's going to be kind of helpful in terms of like when you're reading a vignette. Are these slides available yet? They should be on the drive. I'm going to defer you to Maduka. But yes, I'll usually, yeah, no problem. I'm usually going to post the ones without questions before the session and then the one with questions after the session. So you guys can like refer back to the questions. Okay, so endocarditis, this is going to be an inflammation of the endocardium. So throwback to anatomy when we learned about the endocardium, that's going to be basically the lining of like the innermost lining of the heart. So that's usually where the valves are. So usually this is going to be a valvular issue, and that's why I put valves here, because this is going to be, the valves are going to be the most affected. Usually endocarditis is caused by bacterial infection. So in terms of most common causes, we're going to go through some of the most common bacterial causes. But just keep in mind that there are other causes. I also put them on here. But this is just showing inflammation of like one of the valves. So this is the mitral valve, and then that would be like an endocarditis presentation. So your most common cause overall is Streptococcus viridans. And since, again, micro is obviously more of a thing second year, but micro and pharm are becoming more tested during your first year. So we're going to go through it a little bit. I put like the gram stain and then like how it would look on a blood agar plate up here. I don't know how, I honestly don't know how important it is to know this stuff for first year, but just briefly, it is a gram positive, coccus, but they're found in chains. Anytime you see streptococcus, it means it's going to be found in a chain. So see how this is like a little chain of strep, and then this is like a little chain of strep. It's very different from staph, which I have a picture of that I'll show you later. But strep chains, and it's gram positive, so it means it's going to look purple. On a blood agar plate, strep viridans is an alpha strep, and when they talk about like, oh, it's an alpha strep, a beta strep, they're talking about hemolysis on the blood agar plate. So this is just an agar plate of blood, literally. And it's like when they grow on it, see how it looks kind of like greenish, like in the background. It's just kind of, see how it kind of just looks like green in the background. It's not like going through it's not like eating through the blood. It just has like this discoloration. That's like an alpha. It's considered like alpha hemolysis. Okay. So when they refer alpha, it's not saying that strep viridans is the only bacteria that has alpha hemolysis. It's just saying like the alpha streps look like this on a blood agar plate. So I can't look at this and be like, oh yeah, this is strep viridans. I just know that this is some sort of bacteria that has alpha hemolysis. Okay, and strep viridans has alpha hemolysis. But then you combine it with the gram stain and you see strep in chain, or you see a gram positive coccus, which is a circle in chains. You're like, all right, this is probably an alpha strep that's like a strep viridans type thing. Okay, so overall, this is the most common cause. These guys live in your oral cavity. You have tons of alpha streps in your oral cavity. It's not just strep viridans. You have literally like so many. They're very low virulence, and I say obviously because they literally live in your oral cavity. Like they're not very virulent. But what's big about these is they infect previously damaged heart valves. And we'll get into this, but like let's say you have rheumatic heart disease and then you get like a strep infection in your heart that can cause endocarditis. So anything that like you previously have some sort of damaged heart valve and then you get this infection on top of it, that's going to be your like most common cause of endocarditis. It's because of these strep viridans. I put here like dentists and antibiotics. I don't know if you guys have done cases or if you know anyone in your life, but if people in your life have like heart disease or have some sort of issues with their heart, when they go to the dentist, sometimes they have to take a course of antibiotics before they go to the dentist. And that's why. It's because these bacteria live in your mouth, and if you have a heart issue, you have previous heart disease, you have a murmur or whatever, and then you go to the dentist, you're going to be messing with that oral bacteria, and then it can go to the heart and cause endocarditis. So that's usually why if you see like people that have to take antibiotics before they go to the dentist, they probably have like some sort of valvular disease and they don't want to cause endocarditis. Viridin strep, so this strep viridans can also affect prosthetic heart valves, so literally like metal heart valves that just get put into the heart. But it's a very much later presentation. This is actually like a trick question they like to ask. I'll bring it up when we talk about prosthetic heart valves and like the most common cause, but just keep this in mind. It's not like viridin strep is only previously damaged. It can do prosthetic heart valves, but it's just like it's like years later, like 2 years later. These result in small vegetations, and it results in subacute endocarditis. So anytime you see the word subacute for something pathology, they mean it's like, it's not like super pathologic. It's like you can get away with like, oh yeah, I might be sick. I don't really know. Like it's a subacute infection. You still have like these symptoms of endocarditis, but it's still like, it's not like full on like I'm dying right now type of thing. And hopefully that makes sense. It's a very low virulence bacteria. And then these very small vegetations that it has, they don't actually destroy the valve because again, it's just like, they're like the strep's getting help because the valve is already damaged. And then it's like, all right, cool. Okay. So that's what I think is important about strep viridans, this previously damaged heart valve. Look for things like that. Like look for things like, oh, they went to the dentist a week ago and now they're having these symptoms. And we'll get into what the symptoms of endocarditis are, but this is going to be like almost like your little buzzword. Staph aureus, so Staphylococcus aureus. So like I said, staph and strep, these are both gram-positive, meaning they're going to look purple when you look at them on like a gram stain. But notice staph, they come in like clusters. People say that staph looks like grape clusters because they literally look like clusters of grapes. And that's just what's like, if you see the word Staphylococcus, this is how it's going to look on gram stain. It's going to be like little clusters of purple versus strep, which looks like this, these chains. Like they're purple, but they're chains. Okay, so that's staph. And then notice that staph it has beta hemolysis. So remember, your alpha streps have alpha hemolysis. So when you plate it on blood agar, it looks kind of green. Here it looks like it goes through it like eats through the blood where the colony grows because it eats right through it. That's called beta hemolysis. So when they reference like a bacteria having beta hemolysis, they're talking about how it looks when you grow it on like a blood agar plate. Okay. So this is going to be the most common cause in IV drug abusers, and we'll talk about that. But it's a very, very high virulence pathogen. I don't know if you guys know about MRSA, but MRSA is Staph aureus that is just resistant to certain medications. Super high virulence. Staph aureus causes a lot of stuff. That's why it can actually infect normal heart valves. It doesn't need like a predisposed injured heart valve. It's like, nope, I'm good. I'm pretty virulent. I'm pretty dangerous. I can just infect normal heart valves. But most commonly, it infects the tricuspid valve. So my question to you guys is why? And you don't have to answer, just kind of think about it. Like we have an IV drug abuser that's presenting with a tricuspid valve endocarditis. And if you're thinking about it, how these people get these Staph aureus infections is they're injecting directly into their veins, right? So Staph aureus can be on the skin. It can live on the skin. Right, exactly. So it can, through their veins. So it can live on the skin, and then it gets injected once you inject it, or it's on the needle or something. It goes in the venous system. The venous system is going to go back to the heart. What's the first valve that it comes into contact with? The tricuspid valve. Because remember, all venous blood goes into the right atrium, to the right ventricle, and then it gets oxygenated. So a lot of the times you'll see, most commonly, this IV drug abuser, Staph aureus endocarditis, is the tricuspid valve. Okay, most of the endocarditises are the mitral. We'll talk about it. This is like one of the only instances that it would be tricuspid. So again, since it's very high virulence, it results in large vegetations, and it results in acute endocarditis, not subacute, acute. It's like you know that you're not feeling too hot. This is because the vegetations completely destroy the valve, again, compared to your subacute endocarditis, where it's like the valve's not really destroyed. I also put a note here that there's a certain yeast, it's called Candida albicans. It's also associated with IV drug abuser going to the tricuspid valve, causing an endocarditis. So a lot of the times, like, just keep in mind, like, this is not a bacteria, this is a yeast, but it's the exact same way. It can be present on the skin, it can be on the needle, it can be injected. Everything else is going to be exactly the same. It's just now Candida albicans. It's a yeast instead of a bacteria. Okay, and then the way people remember this is like, don't try drugs because of the tricuspid valve. So, yeah, okay. And then some other bacterial causes. So this is the one I was mentioning earlier. If you have endocarditis, if you have a prosthetic heart valve put in, so again, you have some sort of valvular disease where you underwent like prosthetic heart valve surgery, and then you develop endocarditis, more likely than not, it's going to be this bacteria. It's called Staph epidermidis, and like it's epiderm, like it's thinking it lives on the skin. This lives on the skin. It's a normal bacteria that it's a commensal, just lives on the skin. It lives on your body. And when you put in the prosthetic heart valve, it kind of just contaminates it. So that's staph epidermidis. It looks exactly the same as this because it's a staph, so it'd be gram-positive in clusters like grapes because it's a staph. Okay, and then again, like I said, this is like you get the prosthetic heart valve, and then a few months later you have endocarditis. That's a staph epidermidis. Like I said, the alpha streps, your viridins, can cause endocarditis of your prosthetic heart valves, but that would be much later, like 1 to 2 years later, not like soon, relatively soon after. And then the next one is Streptococcus bovis. So Streptococcus, so it doesn't look like this, it looks like this. So it would be gram-positive in chains, because that's a strep species. And then bovis. This is associated with endocarditis in patients with colorectal cancer. It's just like an association that they had found. So the way people remember this is bovis in the blood, because a lot of the times these bacteria become bacteremic, so they just live in the blood. They can get into the blood, and blood's supposed to be sterile. So once they get in the blood, they can go to the heart and then cause endocarditis. But anyway, bovis in the blood, cancer in the colon. So it's kind of like if you do a blood culture on a patient and it comes back with strep bovis, you're like, ooh, this person might have colorectal cancer. Like, we should probably look at that. Okay? Or if they mention a patient with colorectal cancer and then they're talking about endocarditis, you're like, this is probably strep bovis. And then just a quick side note, if you're doing questions, another name for this strep is called strep galolyticus. I actually don't know why. I just put why not, because medicine, why not? There's can be multiple names for everything. So strep galolyticus and strep bovis are the same thing for some reason. So you can see them either way. But I like bovis because of this little reminder, bovis in the blood, cancer in the colon. And then these are known as culture negative endocarditises. So culture negative means, like I said, a lot of the time these endocarditises are caused by having bacteria in your blood. So you do a blood culture and you have something growing, which nothing should be growing because, again, blood is supposed to be sterile. So if you have culture negative endocarditis, you're like, oh, that's weird. This person has endocarditis, but nothing's growing on blood culture. Super weird. A lot of the times, I'm going to jump down really quick. Usually if you see negative blood cultures, but there's an infection, your mind should jump to a viral infection. But with endocarditis, there's bacteria that just don't grow on blood culture. So that's why I said this makes it a fan favorite trick question on boards, on any like test question. It's like a fan favorite trick question because it's like, there's symptoms of endocarditis, you do a blood culture, nothing grows. You're like, oh God, like this, like, what is it? It's one of these guys. It's got to be one of these guys. So they call them the Hay-Sack organisms. So Hay-Sack stands for Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, Kingella. So that's Hay-Sack. And then there's one other one. This was actually a question I had on boards, and the answer was Coxiella burnettii. So Coxiella also classically causes a culture negative endocarditis. And what I mean by culture, again, it's going to be your endocarditis symptoms, but they take a blood culture, it's negative. Usually they're only going to have one of these guys listed as an option as like answer choices. And you should know it's like one of these guys is your culture negative endocarditis. Okay. A lot of micro, I know. All right, so your clinical features and symptoms. So when I keep saying there's endocarditis, what do I mean? So the first thing is there's going to be a fever because, again, you have bacteria in the blood. So by having bacteria in the blood, the body doesn't like that. There shouldn't be anything in the blood. Blood is sterile. So that can cause a fever response. We'll talk about fever when we get to immuno at the very end of the year. But something I wanted to put here is you can get positive blood cultures accidentally by just having not sterile technique, contamination from like some of the staph that lives on your skin, staph epidermidis lives on your skin, that can show up positive in blood cultures. So what they say is usually when you draw blood cultures from patients, you take like 3 vials. So you literally take 3 separate vials from 3 separate veins because you want to make sure it's like this is in the blood. It's not just like on the skin and I picked it up. Because like the probability of you doing not sterile technique 3 times on 3 different veins is like not that high. So you'll see in vignettes like, oh, like 3 blood cultures were positive, or there was multiple positive blood cultures. That's a true infection. That's not a contaminant. If only 1 out of the 3 was positive, that's like, it's probably a contaminant. Because again, all of them should be positive if it's in the blood, right? It shouldn't just like be there and then be like, nope, it's not over here in this section of the arm. Like, no, if it's in the blood, it's in the blood. So if only 1's positive, you're like, yeah, it's probably just a contaminant. There's going to be a murmur. Like I said, endocarditis tends to be like stenotic or regurg murmurs. It's because of these vegetations on the heart valve. You can imagine it's not letting the heart valves like close properly. A lot of the times with endocarditis, it's a regurgitation murmur, which you can see in vignettes. They'll describe it. And then these are the main three. So these are the main three things to look for. So Janeway lesions, Osler nodes, and Roth spots. So you don't have to see all of them. Sometimes vignettes will give you one, sometimes they'll give you two, sometimes they'll give you all three, but one of these is going to be there, okay? So Janeway lesions are non-tender lesions on the palms and soles. So these are just like lesions. I have pictures of what these look like. Osler nodes, these are tender lesions on your fingers and toes. So people remember this with ouch Osler, because you remember like Osler lesions are painful, ouch. You can also see splinter hemorrhages. This is another one that they can just throw in there and not give you any of these and try and trick you, but then they show you splinter hemorrhages. That's endocarditis as well. And then Roth spots, these are in fundoscopic exam, and I will show you what that looks like, but that's basically when the vegetation, which is just like a little cluster of bacteria on the valve, just now like it embolizes, so it literally gets shot off and then it goes somewhere else, and usually it can go to the eye and deposit like literally in the eye, which is gross. Note, so my note here is they're not going to say patient has Janeway lesions and patient has Roth spots. They're not going to do that. They're going to give you descriptions of these things, and you have to realize like, oh, these are Janeway lesions, these are Roth spots, these are Osler nodes, these are splinter hemorrhages, okay? This is especially important when comparing endocarditis to rheumatic fever, because rheumatic fever has its own set of criteria to kind of keep in track, okay? So what I wanted to do is I wanted to go through you don't have to answer these questions. I just wanted to show you examples of how they're going to talk about endocarditis in vignettes. Okay, so here's an example of your IV drug abuser. So this would be an example of like an acute endocarditis. So like a Staph aureus causing endocarditis. So if you kind of go through it, everything I underlined is what I thought was important to diagnosing it. So he's IV drug using. So he's been using IV like cocaine, heroin, retinal hemorrhages with pill centers. These are your Roth spots. So this is how they're going to explain Roth spots. Grade 3 out of 6, hollow systolic murmur, best heard at the lower left sternal border. This is where your tricuspid valve is. So hollow systolic murmur, that's tricuspid regurgitation. So that nothing from here really like gives it away. It doesn't really help you at all. But then when they're like, oh, they did an echo and they saw multiple vegetations on the tricuspid. So they basically tell you, which is nice. But this is how they're going to refer to like, Roth spots, the murmur, IV drug abuse. Good question. So how will we differentiate lipid deposits in the eyes from Roth spots? Really good questions. I have a picture of the lipid depositions. We're going to talk about that at the very end. That's called corneal arcus. That you can just see looking at a patient. So these lipid deposits, you look into their eyes, you see it. These retinal hemorrhages, you'll see them on fundoscopic exam. So you have to use your fundoscope and then you'll be able to see them, which I have a picture of it and I'll show it to you. Yeah, no problem. So this next one, so this is another one. So this would be your subacute endocarditis. So your Viridin strep, like one of those alpha streps, and they're going to mention a previous dental surgery usually. So here's another one. 5 weeks ago, he underwent molar extraction for dental caries. Dentist, check. And then cardiac exam shows a grade 2 out of 6 hollow systolic murmur, best heard at the apex. That is mitral regurgitation, check. And then they go through the gram stain. Like I really don't know how, if you need to know the gram stain, I have no idea. So I just left it here, but I told you that this is how strep would look. So gram positive, we didn't talk about catalase, but streps are catalase negative, staph's catalase positive, but it's just, they're just trying to say like, oh, strep's here. And then they did echo and they saw a small vegetation. So this is like your presentation. They're usually going to mention some sort of previous, like a dental anything beforehand. Or they'll mention like, this patient has a history of like valvular heart disease and now he has like this like endocarditis type thing. Okay. So this is an example of like when they'll mention like the prostatic valve. So 1 month after undergoing aortic prosthetic valve replacement, they presented with fever, chills, myalgias, joint pain. Yes, I will do that in 1 second. So physical exam shows, okay, so grade 2 out of 6, blowing diastolic murmur after the right sternal border. So this is more of like a blowing murmur. So this is going to be, that's going to be more of like, it's just another murmur. So vegetation on the mitral valve. So a vegetation, I actually think I think it might be in the notes for when I talk about endocarditis, but a vegetation is basically when bacteria colonize a valve and it just looks really gross. Like if I go back to the first slide, like this is a vegetation. It's like, it's just colonization of bacteria on the valve, colonization of bacteria on the tricuspid valve. That's what it, yeah. And then if this is, you can imagine like the heart's opening and closing, the valve's moving around, pieces can get shot off, and that's like what those retinal hemorrhages are, for example, and they can go get sent to like, you know, the retina, like the retinal arteries and whatnot. That's all a vegetation is. A lot of the times there's like fibrin in there, there's like other stuff, but it's usually the bacteria have to colonize it. That's what causes the endocarditis. Okay. And then these are pictures. So this is a Janeway lesion, so this would be painless. They're really like not obvious. These are it. So they're just like these red little lesions that don't hurt if you press on them. These Osler nodes, you can see various pictures of Osler nodes. This is not the only way that they would look, but if you have like nodes, like raised looking nodes on your fingers and toes and that are very painful, that's probably an Osler node. So these are raw spots. So like I said, you need a fundoscope, like you need to do a fundoscopic exam and see these red retinal, like basically these red circles with the pale white centers. These are going to be your Roth spots. So this is literally an embolus, like the vegetation breaks off, it leaves and it deposits in one of like the retinal arteries. And then that causes like bleeding with a pale white center. And that pale white center is supposed to be like where that vegetation like embolized to. And then splinter hemorrhages. This is what splinter hemorrhages look like. Again, very just kind of like the Osler nose. There's variations in how they can look, but just basically like little. They call them splinter hemorrhages because it looks like there's like little splinters of blood. Like it's just very like, you know, thin little lines of blood underneath your fingernails. Those are splinter hemorrhages. Okay. And then you can also have non-bacterial endocarditis causes. These are ones that they might try and get you on. They're tricky. You'll still have symptoms of endocarditis, but they basically do like a blood culture and they're completely sterile. And you're like, that's super odd. So you're like, oh, maybe it's culture negative. So then you try to rule out one of these culture negative forms of endocarditis, and you can't, like none of them are there either. And you're like, well, so then it's like you can kind of start thinking about these non-bacterial causes. There's really only two main ones that are like, you know, important in terms of boards. But so they're called non-bacterial thrombotic endocarditis. And you will get into this when you go into like hem-onc second year. But basically you have these vegetations on the mitral valve. So they're not bacterial. They're just like little like clusters. It's like fibrin. It's like clotting factors. It's like little clots, essentially, like not even clots, like just like little depositions of fibrin and like immune cells and stuff like that. They look exactly like normal vegetations, but usually these are going to be in people with an underlying cancer or hypercoagulable state. And this is because just in cancer, you are hypercoagulable. And that's, again, something you will go into with hem-onc second year. So does rheumatic fever cause that? Rheumatic fever usually causes rheumatic fever can predispose to your strep viridans endocarditis. I don't know 100% if it can cause this type. Usually it's just going to stick to like, oh, this patient has cancer and they have endocarditis and it's not colon cancer. Oh, it might be like that, you know, that non-bacterial cause that just happens in people with cancer. Would endocarditis first present with mitral regurg and progress? Yeah, that's a good question. So yeah, it can progress for sure. A lot of the murmurs can progress. Same with like if you have MVP, it can progress to mitral regurg. Kind of the same thing. So yeah, it can first present with that mitral regurg and then progress. I would just stick to like if you have a murmur of the mitral valve and you have these symptoms of endocarditis, like you're good. It doesn't like always have to be mitral regurg like every single time you do these endocarditis questions. But yeah, great question. And then Liebman-Sachs, this is one that's going to come up again when we do like immuno. We're going to talk about lupus during immunoblock. So lupus, systemic lupus erythematosus. It's an autoimmune disease. Lupus is really interesting. We're going to go a lot into it. But for whatever reason, they noticed that patients that have lupus tend to get this Liebman-Sachs endocarditis. I think these are just the two guys that discovered it because they wanted to name it after themselves. But basically what's really interesting about this one is, so it's sterile, so the blood cultures will be negative, but they're not like, oh, this might be a culture negative endocarditis. There's a really weird feature about Liebman-Sachs is you get a vegetation on both sides of the mitral valve. So if I scroll kind of back to this, see how in this image of normal endocarditis, it's like, okay, they're over here on this side of the valve. Lippmann-Sachs would be like, okay, the valve is like this, it like closes, and then you get the endocarditis on this side, and you get it on the opposite side. So you're like, that's super weird. That's just what happens in lupus. It's something that happens with lupus. You can get just deposition of like immune complexes, fibrin on both sides for some reason. So if you see like endocarditis, like if you see like vegetations on both sides of the of the mitral valve, you're like, okay, this is Lippmann-Sachs, this is a lupus type thing. And of course, it can also lead to mitral regurg. Okay, so those are the two like non-bacterial causes that might come up. And then I'm going to go into rheumatic fever. So I'm going to start with acute rheumatic fever. This is the one that tends to be asked more about like in questions and stuff. But it's more micro, if you can believe it. But this is basically when strep throat leads to valve disease. So that is what all rheumatic fever is. So we have another microbe that you should know. It's called Group A Streptococcus. So before we dissect all the names that it has, Group A Streptococcus. So it's a Streptococcus. So it's going to be gram-positive in chain. So it's going to look exactly like the strep viridans did. You're not going to be able to tell just by looking at the gram stain what type of strep it is. You put it on blood agar, and now it's beta hemolytic. So it eats right through that blood, which if you can remember, the viridin strep did not eat through the blood agar. So you kind of use both of these and you're like, oh, this is a beta hemolytic strep, like strep species. It's probably group A strep. Okay. And then group A strep, all this group A means is like when they were naming it, it like reacted with group A like material, which again, we will go into this in immuno. But the actual name of it is called Streptococcus pyogenes. So Streptococcus pyogenes, pyo means like pus forming. And if you've ever had strep throat and you look in the back of your tonsils and there's all those white dots, that's pus. So that's kind of where it got its name for strep throat. This is the causative agent of strep throat. So like this is the guy. So I just wanted you to be familiar of these terms because they can refer to it as group A strep or Streptococcus pyogenes. They're the same thing, okay? But that's where it got the name pyogenes because it makes pus in the back of the throat, like on your tonsils. Okay, and then this rheumatic fever is going to arise in children, so it's really not adults. It's usually going to be children. I never say never, but it usually is children, and it's going to be 2 to 3 weeks after strep throat. So imagine some sort of valvular issue 2 to 3 weeks after strep throat, and it's going to be caused by molecular mimicry. And molecular mimicry, we will have a whole discussion on it in immuno. Basically, at the very least, strep pyogenes makes something called M protein. For some reason, it's called M protein, and it looks exactly like valve tissue. So the immune system gets really confused, and it's like, oh, I'm going to get rid of this strep. I'm going to make all these antibodies against M protein, and then they get confused, and they attack the valve accidentally. So this is kind of like an autoimmune mediated thing, but it's always triggered by group A strep, strep pyogenes, strep throat. And I'll show you like some vignettes, like some examples of vignettes. There will always be strep throat mentioned, always in the vignette. So that's the main difference with endocarditis. Okay, and we'll go into like why is it 2 to 3 weeks before, what the heck is molecular mimicry. We will go into that in so much detail, but just understanding like strep pyogenes, this is what causes rheumatic fever. And then, so diagnosis is going to be based on these anti-group A strep antibodies. So you're going to like probe basically for, let's see if this patient has antibodies to group A strep, because if they don't have antibodies to group A strep, they can't have rheumatic fever because it's because of group A strep that you have rheumatic fever. And then there's also minor criteria and major criteria. So minor criteria is like what you would imagine in anyone that's sick. Fever, signs of inflammation. So I don't know if you guys have been ordering any of these tests in your cases, but usually they'll say like a sedimentation rate or like a C-reactive protein. These are just very nonspecific. Like they're very nonspecific. It just means, yeah, like inflammation is happening in the body. So fever, signs of inflammation, these are minor criteria. Major criteria is called Jones criteria. This is like an absolute need to know. It's kind of like those 4 things for endocarditis are like giveaways in vignettes. Jones criteria is like, this is how you diagnose rheumatic fever. And in terms of like actually diagnosing rheumatic fever, you need either 2 major criteria and no minor criteria. Or, I mean, you can have more. It's not a big deal. But at the very least, you need at least 2 major to say like, yeah, this is rheumatic fever. Or you need 1 major and then at least 2 minor. Okay. And you'll see that because like that question comes up sometimes. Well, like, how do I know that this is rheumatic fever if they only talk about this one thing? And it's like, well, if they only mention like what the J stands for in Jones criteria, and then they say patient has a fever and like, this non-specific sign of inflammation, you can be like, okay, that also counts as, diagnosing rheumatic fever. That's what kind of makes these questions tricky, but I have examples again of vignettes, because you don't need all of this in a vignette. That's why it's like, oh, like what is this? I don't actually know what this is. And then the acute attack usually resolves, like the body gets rid of it. Like it basically like it stops making these antibodies against the heart valve all on its own, but sometimes it never stops and then it progresses to chronic. And we'll talk about some of those risk factors. But this is Jones criteria. So like on your exam too, like on your little scrap paper, you should just write out Jones and like have these like in your mind. So when you're doing vignettes, you can see if any of these pop up, but we'll go through these one by one. So J stands for joints. The O is technically a heart. So like if I could have, I would have wrote like Jones with a heart. That's like what I do when I write Jones criteria. And then the heart is like pancarditis. Pan, remember we talked about this last time. Pan means every. So like endocarditis, myocarditis, pericarditis. And I just we'll go into it because I'm going to talk about those two also. N is for nodules, E is for erythema marginatum, which is just a rash, like a specific rash I'll show you. And then that's not how you spell it. I think it's SYD. So Sydenham's chorea, which I'll also talk about. Okay, so this is Jones. This is like, you need at least 2 of these or 1 of these with 2 other signs of inflammation to diagnose rheumatic fever. So joints, so the J is for joints, and this usually what the joints is, it's a migratory polyarthritis. So migratory means it kind of seems like it migrates around the body, like your arthritis jumps. So you'll have like pain in the knee 1 week, and then the next week you'll have pain in the ankle, and then it'll go back to the knee. It'll go from the right knee to the left knee. It's moving everywhere. Usually this type of arthritis is in like the bigger joint. So like knee, ankle, really not the wrist. It's not impossible, but it's just usually the bigger joints. Okay. The O in Jones, remember, is a heart. So this is pancarditis. This is the key issue with rheumatic fever, obviously. That's why we're talking about in cardio block. But for example, you're going to see an endocarditis, which again makes it kind of tricky because remember I said like rheumatic fever can be a trigger for endocarditis because it damages the heart valves. Imagine your immune system just attacking the heart valve. That's a good trigger for now that alpha strep to jump and be like, cool, it's already halfway like damaged. Let's just finish the job type of thing. Usually it affects the mitral valve more than the aortic valve, but the aortic valve can be affected. It's just way more common in the mitral valve. And when the endocarditis forms, the vegetations are along the line of closure. So it's kind of not allowing the valve to close properly. So that's why typically you'll see regurgitation. Myocarditis is the next layer in this pancarditis, and this is the most common cause of death during this phase. So before the body can even like stop having like the attack on the mitral valve, people can just die, and they'll die of myocarditis. We'll go into myocarditis, but usually when they take like a little biopsy of the heart muscle tissue, like they'll take a biopsy of it and look at it, you'll see certain cells. These are like little key like cells for diagnosing. And then pericarditis. Pericarditis we've talked about before. Symptoms of this, but we'll go into it later. This is your friction rub, and then this is going to be like you take a deep breath in and it really, really hurts. It feels better when you lean forward. That's usually like your signs and symptoms of pericarditis. But we'll go into it when we talk about these more in depth. So the 2 types of cells, so these would be in like, again, the heart cardiac tissue, like the actual muscle tissue itself. So they're called Aschoff bodies. And Aschoff bodies, it's just this massive thing here. So again, you can notice the striations, like if you did any cardiac histo, like looking at the actual striations, these look like cardiac striations, like for the gap junctions and whatnot. And then you'll see this giant, massive ball of cells, and you're like, that shouldn't be there. That's called an Aschoff body. It just means that there's inflammation of some sort happening. If you zoom in on one of these little cells that are in here, those are called, I have no idea how to pronounce this, Anichkow cells? I have no idea. But they're like they call them histiocytes. We'll talk about histiocytes in immuno, but they're just cells that have what's known as caterpillar nuclei. And I really don't know what this is. It's more of like, I don't know what these are. These are just more so indicative of myocarditis caused by rheumatic fever. They're almost like little triggers for like buzzwords for rheumatic fever. So we'll talk about like why pericarditis feels better with leaning. I don't think they know, but I have like a theory as to why, but we'll talk about it when we get to pericarditis. And then here are the nodules. So the N in Jones criteria is for nodules. So there's these subcutaneous nodules. And again, don't get confused with, again, nodule. We're going to talk about nodules because of hyperlipidemia. You get like these nodules depositing everywhere. And also with endocarditis, you have like the Osler nodes. Just keep in mind, these can be anywhere. So I tried to put as many pictures as I possibly could of just like where you can find nodules. So like the elbow, the knuckles, the foot, like just these it's just going to be like, this can't just be diagnostic. You have to be like, okay, I also have to take into consideration, did they also have strep throat? Do they want me to pick rheumatic fever for this question? So just keep in mind, that's what the N is. It's subcutaneous nodules. Here's erythema marginatum, and for just right off the bat, what I can think of, don't get confused with like Lyme's disease, the bullseye rash in Lyme's disease, because that also presents with a carditis. Remember that Lyme's disease can present with carditis. It can present with third-degree heart block. So just keep in mind that if there's a heart issue and you see a rash, don't be like, oh my God, it's Lyme's disease. Like that's definitely Lyme's disease. It could just be the E in Jones criteria, and look for strep throat in the prompt. Like do that, because they like don't just pick Lyme's disease because you see a heart problem with some sort of red rash on the body. But erythema marginatum, it kind of looks like a bullseye rash. They won't call this a bullseye rash. They'll say like, oh, like it's this non-itchy rash. They call it annular because it's like there's these circles in it and there's these red borders. So it's kind of like outlined in red, but they won't refer to this as a bullseye rash. And then usually this is going to be on the trunk and the limbs, and there's going to be multiple of them. With Lyme's disease, you only have like one, and it's like that's where the tick bit you. Here, it's like, it's a giant rash. So it can be on the trunk, it can be on the limbs, it can be kind of like anywhere. And then the last one, this is Sydenham's chorea. Chorea, I know it's a weird picture, but chorea is really hard to put a picture up of. So I'm going to have like vignette prompts explaining what chorea is, but you'll see chorea with like Huntington's disease. So when you do neuro, like it's going to be the exact same presentation, like chorea in Huntington's disease to this chorea here. It's basically just like these, I tried to explain it as like just rapid involuntary muscle movements. And I'll show you how they would word it in a vignette, but it's like, just like this image, it's just like this little boy is making these really rapid, random muscle, like he's not trying to do this, it's just happening. So just that's what chorea is. And again, it's usually going to be in little children because that's acute rheumatic fever usually is in children after having strep. Huntington's is in like adults that have the Huntington disease. But don't worry about that. It's when you talk about Huntington, it's going to be the same thing. All right. So I put a lot of vignettes because rheumatic fever can be tricky because it's going to be different depending on what of Jones criteria is present. So I tried to put as many as possible. I wanted to give you vignettes with at least all of them so you can see how they would be like worded. So this one is O for your pancarditis as well as your N for your nodules. So the first thing you want to look for is sore throat. So that's kind of like a little trigger for like, okay, I can call, like I don't know what the rest of the prompt says, but it says sore throat. This could have the potential to be acute rheumatic fever. They could put it in there to try and throw you off, and then they ask about endocarditis. That would be really mean, but they could do it. That's why you have to look at Jones criteria, see if it's in there. So chest pain that's more severe if you take a deep breath, that sounds like pericarditis to me. Again, we'll talk about pericarditis like in a little bit. What else? So subcutaneous nodules on the elbows and wrist. Yep, that's your N for nodules. And then there's some sort of murmur. So there's a systolic murmur, best heard at the apex. That is your murmur from the attack on the mitral valve. Okay, so this is an example for the O and the N for Jones criteria. Here is one for the joints and the nodules. So again, look for sore throat. Awesome, sore throat. So this patient had severe right knee joint pain and swelling. And then, so for 3 days, then 5 days ago, they had swelling and pain in the left ankle. You're like, okay, weird. And then you're like, okay, so sounds like migratory joint pain. And then if you jump down, it's like there's these painless nodules on the elbow. Those are your nodules. Those are your subcutaneous nodules. Again, these can be anywhere. It doesn't have to be the elbow. And then they talk about, other stuff like, oh, like no organisms are on gram stain. It's not, remember, this is not being caused by the bacteria. It's the immune system attacking the valve because of this infection you had like 2 to 3 weeks ago. The bacteria is not even there anymore. It's just like, now it's the immune system just like attacking your valve. Like, oh, I think it's the bacteria. Let me just attack it. Okay. So this is for a pancarditis as well as the erythema rash. So sore throat, awesome. So shortness of breath. So this one is kind of them trying to explain myocarditis that is like going into basically heart failure. And that's how it can also present in a vignette. If you have remember, myocarditis is like the #1 killer for acute rheumatic fever. Sometimes they don't even progress to chronic rheumatic fever because it's just like they die of myocarditis. So this is an example of like the myocarditis causing like basically heart failure. So if you go through it, it's like symptoms of heart failure. So like shortness of breath, jugular venous distension, ankle edema. And then they talk about this erythematous ring-shaped macules and patches over his trunk that are well demarcated. So when you see well demarcated, this means, again, remember how I said there's like this nice red border? It's like that is like it's a nice demarcation. Like it's like someone took a marker and like drew a nice circle where the rash is. Some rashes aren't demarcated. There's no true border. It just kind of like fades. So that's definitely how I would describe this type of rash. And then they talk about crackles, this S3 gallop, like this person is not doing too hot. Cardiac silhouette enlargement. So this is kind of like your myocarditis, endocarditis, pericarditis. Like something is itising in the heart because the heart now is bigger. The cardiac silhouette is larger on, so you have cardiomegaly. That can be from the inflammation causing like just the heart to look bigger. So that's this one. So again, you can see how these can all present differently. And then I wanted to find one with the Sydenham's chorea because I think that again, like I said, it's like these rapid movements can present in so many different ways. So right off the bat, they tell you like there's involuntary non-rhythmic movements of the arms and legs. That's like that kind of sounds like chorea. And then look for your sore throat. Yep, cool. So you can kind of be like, yeah, that's probably chorea, but let's keep looking. And then I just basically highlighted everything that they say to kind of look for in vignettes to describe Sydenham's chorea. All of these might be here, all of them might not be here. And maybe it's just this first one here, like these involuntary movements in a patient that had a sore throat like at least 2 weeks beforehand. So some of the things that they describe as seeing in vignettes for chorea, rapid onset of these involuntary purposeless movements, emotional lability. So they're basically saying like super, super emotional, like super emotional. So it's saying like, oh, like this patient has become increasingly irritable and inappropriately tearful. So it's kind of like super emotional for absolutely no reason. Hypotonia, so hypo means like decreased tone. So this would be like decreased muscle tone. So that would present with like, muscle tone is decreased in all extremities. Then the two like more defining features, milkmaid grip and choreic hand. So milkmaid grip is an inability to sustain a contraction. So it's like you have the patient grab onto like you and then basically they'll be like going like this. It's like they're contracting, then they stop, then they're contracting, then they stop. And it's because, again, they can't control they're just doing these involuntary movements. So they can't hold a sustained contraction because their body's just involuntarily like doing all crazy things with their muscles. And then yes, exactly, like milking a cow, milkmaid grip. They talk about milkmaids a lot, and like you'll see a lot of like milkmaid stuff that they call stuff. They use milkmaids a lot. But yes, exactly. So it's like you're milking a cow. Love that. And then choreic hand is you basically tell, and they talk about it here. So when the patient holds her arms and extension, flexion of the wrist and extension of the metacarpophalangeal joints, MCPs, so like your knuckles basically. So it's kind of just like saying the wrist, so you tell the patient to extend their arms, they flex the wrist and then extend their fingers. So again, it looks, kind of like this. So it's kind of like they're making these really weird hand movement. So they're flexing the wrist and extending I can't do it that well. This is what it looks like. So this is the choreic hand. And again, it's very common when you have chorea, again, rheumatic fever, Huntington's disease, like to make this is like a choreic hand. It's like the defining feature of chorea, basically. Okay, so these are all just, I liked this one because it gave you every single thing you could possibly see about chorea, but just note that maybe like even one of these might be there and that's enough to count it. But really look for that sore throat and then look for just other Jones criteria. Okay. And then let's say, so I have here like assuming survival of myocarditis. So you have acute rheumatic fever, you survive that myocarditis, and now we go into chronic rheumatic fever. What happens now, it's chronic. It's kind of like the immune system just doesn't stop attacking the valve. So sometimes it'll just go away, like acute rheumatic fever, or just like your immune system just stops. Sometimes it just continues. That's chronic. Just imagine the immune system constantly attacking this valve. The valve's going to scar. And this is more like commonly presenting as stenosis, because just think of a giant scar on the mitral valve. Again, its mitral is greater than aortic. Aortic can still be affected, but a lot of the times it's going to be mitral more so. And then the scarred valve, they say it has a fish mouth appearance, which is really gross, but I'll show you a picture. And then if you have mitral valve chronic rheumatic fever, this is going to be like thickening of the chordae tendineae. So the things actually holding the valve going to get thick, and then the cusps are going to get really thick. If you have it of the aortic valve, the actual commissures, so the actual like valves of the aortic valve can like almost look like they're fused together, and that can lead to stenosis as well. So this is more so like, this is like a chronic state of this rheumatic fever, is like your stenosis. Here's your fish mouth appearance, really gross. So this would be like just a valve that has massive scarring, and then it, I guess, looks like a fish mouth. All right, but just keep that in mind. Yeah, I don't know. Okay, so next is myocarditis. So this is going to be inflammation of the myocardium, so the actual muscle tissue. So we talked about, those anetsukow cells, which are within the Aschoff bodies. That would be like if they took like a biopsy of the muscle, they would see cells like that. Gonna give you like my, not tricks for vignettes, but usually this is going to be in young adults, myocarditis. I don't know if you guys remember when the COVID vaccine first came out, a lot of people were claiming like, oh, like the 18, 19, 20-year-olds that were getting affected from this were all getting myocarditis. And and I don't know if that's going to help you just like associate it with like younger people, but that was like the big like deterrent for like, oh, like if you're young, don't get the vaccine because like you don't need it because you're probably not going to die of COVID and you might get myocarditis. So that can like almost help you remember that, maybe. I don't know. But so usually it's these young adults, usually it's young adult males. And commonly it's because of a viral infection of some sort. Again, myocarditis is idiopathic. They don't know actually what's causing it. They obviously know it's immune mediated for some reason. But the viral infections that this actually came up on my exam first year was they talked about a 21-year-old boy that they would go into like some symptoms of like cardiac inflammation, and then they said he had an upper respiratory tract infection like 2 weeks before. What was probably the causative microbe, and Coxsackie. So Coxsackie, A or B, either one, it causes upper respiratory tract infection. So if you note it, and same with parvovirus. Parvovirus causes a lot of stuff, but it causes upper respiratory tract infection. So like just imagine like this 21-year-old that just got like caught a cold basically, and then like 2 weeks later now he's having these heart symptoms. That's probably Coxsackie. That's probably myocarditis. Acute rheumatic fever can cause this. Remember we talked about pancarditis. So you can see symptoms of myocarditis there, as well as autoimmune disease. So autoimmune disease, again, can just attack the myocardium for whatever reason. And they just found like an increased instance with lupus and vasculitis. But again, just keeping in mind, I really feel like it's going to be like that upper respiratory tract infection. And now there's these cardiac manifestations. So how does myocarditis present? So usually it's asymptomatic. So usually they don't even know that they have it, but it's going to be like, if they're asking about some sort of cardiac issue and the patient's like, oh, like I had this upper respiratory tract infection like 2 weeks before, you're like, nice, this is probably myocarditis. So it can be asymptomatic, or it can just be like signs of inflammation, like flu-like symptoms. You have like joint pain, muscle pain. Just think about having the flu. You have fever, joint pain, like you just feel blah. You can see fatigue, weak. Just notice it's very nonspecific. So that's why I'm saying like this upper respiratory tract infection 2 weeks beforehand is like key for myocarditis. Again, everything you see with myocarditis is nonspecific. So like you can see basically anything on the EKG. I love that you can see both tachycardia and bradycardia. Like those are exact opposite things. So you can see anything. And then if sometimes myocarditis and pericarditis happen together, and if you get the pericardium involved, you can see that positional chest pain, which we'll talk about. And if you don't treat myocarditis, it can progress to dilated cardiomyopathy. It usually doesn't, it usually just goes away on its own. But again, just wanted you to keep in mind these viruses. So Coxsackie A and B, and then parvovirus B19. And then pericarditis, so this is the one I talked about in the EKG one. This is like one of the EKGs I think you should be able to recognize. But this is when the pericardium becomes inflamed. So remember, the pericardium is the sac that surrounds the heart. It's just like the pleura. The pleura surrounds the lungs. The pericardium surrounds the heart. And remember, if you get a cardiac tamponade, that's the space within the two layers of the pericardium filling up with fluid. And that's your classic cardiac tamponade. So this is just inflammation of the pericardium. So a lot of the times they know like viral infections can cause it. It's not as specific as myocarditis. Like I don't have specific viruses listed here, but you don't really need it. A lot of the times you can diagnose it with the clinical features. So there's going to be a fever, obviously, because they're pretty sure like some sort of infection causes it. But with this, you'll see this pleuritic chest pain. So like I said, pleuritic chest pain is like chest pain that occurs. It gets worse when you take a deep breath in, and it gets better when you lean forward or if you just sit. Now the question earlier is like, why does it get better? And they don't actually know. There's like actually not a reason why. I think since it's inflammation, and again, the heart is like right up against the chest cavity. I think since it's like the inflammation is what's causing the chest, is like what's causing your chest pain. So when you lean forward, you're kind of having like gravity, like almost give it a hug. Like you're like giving the pericardium a hug. You're like, you know what, it's gonna be okay. Like you're pressing it against, you're like not allowing it to be as inflamed, if that makes sense. It's kind of like when you like hurt yourself or you hurt your hand and then you your automatic response is to like grab it and be like, ow, like that really hurt. That's kind of what I think why it feels better when you lean forward. It's kind of like you're making it harder for the inflammation to cause pain. That's what I think. I have no idea, but just understanding inflammation, that's what I think is happening. But just look for it in vignettes. It will always be there for pericarditis. And then you can hear a pericardial friction rub and auscultation, which I have a clip. We're going to play it and see what it sounds like. But it's also self-limiting, meaning it goes away on its own. It just kind of comes and goes with these viral infections and it can go away. And then again, look for those diffuse ST segment elevations across the EKG. So I have another picture that's 100% something that you should be able to recognize. Just every single lead has an ST segment elevation. So a STEMI, every single lead. So it can progress to a chronic form. This is like when you have it for more than 3 months. And when it does progress, that's when you can actually get cardiac tamponade, because then you're going to start having like fluid buildup just from inflammation, and just this tons of inflammation causes fluid. So that can lead to tamponade. And then more about that chest pain. So again, it improves when sitting, improves when leaning forward, and it's retrosternal. It's right behind the sternum. All right, let's see if this works. Oh, it might. So you guys hear that? So this is like when you're listening to the heart, you would just hear this. So some people say this sounds like walking through snow. Oh, you can't hear it? Oh man. All right. Well, all right. Well, just imagine walking through snow in snowshoes. That's what it would sound like. So if just listen to it here. I had a feeling it wouldn't work. So here's the link here. But again, it's just like they'll say like, oh, pericardial friction rub was heard on auscultation. This is what they're referencing. Okay. Here's your diffuse ST segment elevation. So pretty much every single lead has an ST segment elevation. So like literally almost every single one. That's very indicative of pericarditis. And then especially when you couple it with the positional chest pain that gets better when you lean forward or when it hurts when you take a deep breath in. And then I wanted to remind you guys about Dressler syndrome. So this is in like the recorded anatomy session that I put up. I went into evolution of an MI because I think that that's actually really important, and it's also on your syllabus. So I did go through that in the re-recording of the anatomy presentation. But in it, what I talked about was like 2 to 10 weeks, so huge range after an MI, and now you have pericarditis. That is called Dressler syndrome. So there's no true cause. You didn't have like a viral infection beforehand. You just had an MI like 2 weeks ago, and now all of a sudden you have pericarditis. That's called Dressler syndrome. Again, no clue what causes it, just like with lots of stuff in immuno. They have no clue what's causing it. They think it's now because it's like the immune system just thinks that the pericardium is not supposed to be there. It's kind of like maybe they think like the heart architecture looks different after you have an MI. So like these autoimmune reacting antibodies can just attack it. And that's kind of what happens. But the exact same signs and symptoms of pericarditis, it's going to sound exactly like pericarditis, like when you're reading the vignette, but there's going to be that little sentence in there that said like the patient sustained an MI like 4 weeks ago, 5 weeks ago, 2 months ago, something like that. That's called Dressler syndrome. Okay. Okay. So those are the cardio stuff. We're going to do questions at the very end, but I wanted to go into some renal stuff. So again, strictly focus, because again, 1 week out from your exam, so strictly focusing on the types of things you wanted me to go into in terms of what was on the syllabus. So I'm just going to be going through, this is everything I'm basically going to be going into. So I wanted to start with acute kidney failure because I feel like it envelops everything. So this is acute. So it develops within days. It happens super quickly. It's like all of a sudden this patient just starts like dying and you're like, what the heck happened? You have this absolute severe decrease in renal function. And usually they look at kidney failure with GFR, like what's happening with like your GFR, what's happening with your BUN and creatinine. And the reason why is because a hallmark, so diagnosing someone with kidney failure, you need what's known as azotemia. So azotemia, temia again means blood, so emia it's in the blood. Azo means nitrogen. So there's like basically these nitrogenous bases, like these nitrogenous waste products just build up in your blood. Usually that shouldn't happen because the kidney gets rid of those. It's like, here, like I'm going to filter these and you're going to just pee them out. But the kidney's failing, so it can't. So they build up in the blood. And that's why they look at azotemia as like a hallmark for kidney failure. Usually it's coupled with oliguria. Oliguria, remember from Potter syndrome. Oligo means scanty or decreased. So this is like decreased urine. Just like with Potter's oligohydramnios, decreased amniotic fluid. Decreased urine. So this is usually directly because of this decreased GFR. So a lot of the times you look for signs and symptoms of azotemia with the decreased GFR, or like they're saying like, oh, they can't really, like they're not really going to the bathroom that much, or they have very, very low GFR on blood work. So how does azotemia present? Usually your BUN and creatinine increase. We'll talk about like the different ratios. When I was facilitating last week, some of you guys were going into those ratios, which was awesome because it is good to kind of keep in mind what's causing the kidney failure, and you can get that from the ratio. So usually with this, it's divided into pre-renal, post-renal, intrarenal azotemia. So it's kind of like, all right, acute kidney failure, the hallmark's azotemia. What type of azotemia is it? That tells you what's causing the kidney failure. So I'm going to go into it very briefly, just like one slide on each. So pre-renal azotemia, we already talked about. So this is like the cause of the azotemia is before the kidney, pre. So it's before kidney. So this is basically heart failure leading to kidney failure. That's why you do cardio-renal together, because they're very, very similar in terms of like something happens in the heart, kidneys are going to be like, yeah, it's not going to work. So basically pre-renal azotemia is decreased blood flow going to the kidneys. And it triggers kidney failure. So again, heart failure, that's usually why blood flow decreases. Doesn't have to be the only cause, but I highlighted this because this is the most common cause of kidney failure is heart failure. So this decreased blood flow to the kidneys decreases GFR. Again, this is before RAS kicks in. So it decreases your GFR. You get a buildup of the nitrogenous waste products in the blood because GFR is down, so everything kind of backs up, and then you get oliguria because of the decreased GFR. RAS will eventually kick in, and then you get that reabsorption of fluid and BUN. And when I say BUN, it's those blood urea nitrogen. So again, those nitrogenous compounds are like kind of considered within that BUN. So aldosterone causes sodium reabsorption, water follows sodium, you guys know this. BUN follows water. So this is me putting you onto something new here. BUN follows water. So if water's getting reabsorbed, BUN, those nitrogenous waste products are going to get reabsorbed. So they say, like, if you do a BUN creatinine ratio, it should be greater than 15. And again, don't know how important it is to memorize these numbers. I just kind of wanted to give you an idea of like the cause of the kidney failure can be determined from this ratio. And this makes sense. Hopefully you don't have to memorize it. It's because creatinine is usually like your breakdown product. That's not really being affected with pre-renal azotemia. It's really the BUN, which is those nitrogenous waste products. So they're going to get reabsorbed because RAS gets kicked in. So the ratio is going to be higher. Because again, BUN's not the denominator is on the bottom. The numerator, BUN's the numerator. So if this goes up, then the entire ratio goes up. So that's why we have an increased ratio with pre-renal azotemia. Okay, because BUN just follows water. Next, so I skipped intrarenal. I just went right to post-renal azotemia. So just like it says, the cause of the azotemia is after the kidney, post. So again, imagine what would cause you to not be able to get rid of waste products now after the kidney. An obstruction. So some sort of obstruction of the urinary tract downstream of the kidney, aka a ureter obstruction. So this is kind of where it gets a little tricky. It's kind of like the early stages of the obstruction. Because again, we have our kidneys. That's I swear that's a kidney, and then we have the ureters going down to the bladder, which is over here. So let's say we have an obstruction right here. The first thing that's going to happen is, fluid is going this way. Well, it's going to just like build up. So it's like there's increased pressure in these tubules, and it's basically like forcing because of this. And this is the best way for me to describe it. You'll go, like I said, second year, you'll go way into this, like into so much depth. But how I can think about it and explain it really easily is this increased pressure in these ureters almost force these nitrogenous waste products to just go into the blood. So it's kind of like, all right, like there's this increased pressure, you're just going to go. You don't have room here. Go back into the blood. Eventually, you're going to have long-standing obstruction, so then the actual tubules in here are going to get damaged, and then you're not going to be able to even reabsorb. Even if they're being forced, it's like, nah, we can't reabsorb it. We don't work anymore. And that's when the ratio drops. So the BUN creatinine ratio is going to drop. So if you see like this change from like greater, like a high ratio to a low ratio, that's more of like an obstruction kind of like standpoint in terms of like it's early, it's like forcing BUN reabsorption, and then later it's like, yeah, we don't work anymore, we can't reabsorb BUN even though you're forcing it over here. Okay, and then intrarenal azotemia. Again, intrarenal azotemia is basically like the kidneys themselves are the problem, and this is where you start getting into like really deep into renal path, and this could have been its own like session. But like I said, second year, I'm again not saying this can't be on your exam, but I'm just saying in terms of like, there's so much renal path that it's like, I don't even know if it would be worth it at this point to like try and memorize it. But I give you the top 3 at least. But in terms of this, so intrarenal azotemia, you have this buildup of nitrogenous waste products because the kidneys themselves are the problem. They themselves are sick. They're like just, you have sick kidneys, they don't work. So obviously you can't reabsorb BUN, so your ratio is going to be low. So the 3 main that I came up with was acute tubular necrosis, acute interstitial nephritis, and renal papillary necrosis. Lots of words. So acute tubular necrosis, this is when the tubules, so the renal tubules, die. So you get injury and necrosis of the epithelial cells in the tubules. A lot of the times this is mediated by drugs. I'm pretty sure NSAIDs can also cause acute tubular necrosis, but a lot of the times it's like drug, like you did something to completely kill the epithelial cells in your kidneys. Acute interstitial nephritis is going to be same thing. Like it's usually going to be like a drug-induced something. So like an NSAID. Again, NSAIDs are very toxic on the kidneys. So you have drug-induced. So you take an NSAID, and then for whatever reason you have an allergic reaction in the kidneys. Again, they don't know why, but that's why it got its own disease. It's like these NSAIDs for whatever reason cause an allergic reaction, and now the immune system's attacking your kidneys basically, and that's going to cause, your kidneys to be sick. And then the last one's renal papillary necrosis. This is when the actual renal papilla, so if you go back to the anatomy session to look at where are the renal papilla, they just die. They think, again, all of these are like, this is what they're associated with, but they don't actually know why it happens in some patients and not others. But more likely than not, when you have just death of the renal papilla, it's because you've been taking like aspirin, even honestly NSAIDs here, like some sort of COX inhibitor. Like you've been taking aspirin, NSAIDs for just a very, very long time to the point where they're just damaging the kidneys this way. Diabetes does this, as well as sickle cell anemia. So sickle cell anemia can also cause this. Sickle cell causes this for a totally different reason. You'll get into it second year. But basically, sickle cell anemia, the red cells sickle, so they look like literally sickles, and they just get stuck in the kidneys, and that's why the cells die. Because now it's like the kidneys aren't getting oxygen; they're just dying because they all these cells are getting stuck in them. But these other two, they just notice an association with both of them. All right. So a lot of the times when, for example, in the syllabus, it says the consequences of acute renal failure. If you have acute renal failure and then you kind of just live your life with this, with kidney disease, they call that chronic kidney disease or CKD. If you have CKD, so this is just you have kidney disease for forever, usually you're going to die from end-stage renal disease. So this can actually be a diagnosis at your time of death. cause of death. That is the name. So end stage renal disease, ESRD, can actually be like, that's your cause of death. And this is like something happens to the glomerulus, something happens to the tubule, something happens to like an inflammatory nature or like a vascular insult. Again, it can be one of these guys back here, you just have this for a very, very long time, and it leads to chronic kidney disease. So this decline in renal filtration, excessively retained nitrogenous waste products, and electrolyte disturbances. And I put this here, and I'm going into this because of the side effects and the consequences. They were all in your syllabus. So the main clinical feature of chronic kidney disease, just like acute renal failure, is uremia. Uremia is the name that some doctor somewhere gave to all of the different types of clinical manifestations that you can see because of having nitrogenous waste products in the blood. So it's kind of like, this is like going a step further from acute kidney disease. It's kind of like, all right, if the buildup of the nitrogenous waste products just stays forever and ever, and now I have chronic kidney disease, now you can consider that to be like uremia. And so basically, again, it's because of that decreased GFR, but uremia causes weird stuff that doesn't actually make sense logically. It's like, these are just classic associations. So for example, uremia can cause platelets to be dysfunctional. They don't know why. So like, you can have a patient with chronic kidney disease presenting with bleeding. You're like, well, why? And you're like, oh, platelet dysfunction, probably from the uremia. You can get encephalopathy with asterixis, and I'll talk about asterixis because I'm pretty sure I put this in a question later, but it's like you have the patient, they make like it's called like a flapping tremor. So it's kind of like they push their hands out. I'm not going to do it because I can't do it, but then they start flapping their hands. So like they extend their arms and then their hands just start flapping. They're not trying to do that. It just happens. That's what asterixis is. And usually it's because of uremia. And encephalopathy is just like brain issues. You'll get into that with neuro. And then nausea, anorexia, pericarditis, and deposition of urea in the skin. So it's just like this clinical constellation of symptoms that you can see in a patient with kidney disease is just called uremia. So if you've ever wondered what uremia is, it's like a clinical diagnosis, and it's because of elevated levels of BUN in the blood, which is usually caused by decreased GFR because of pre-renal, intrarenal, post-renal azotemia. Does that make sense? So we're kind of like going a step further because, again, this is where, on the syllabus, this is where all these symptoms were. And then before we go into the symptoms that you can see, it's basically just like consequences of uremia. I wanted to talk about renal osteodystrophy because this is like something really cool. You'll go into this more into when you get to endo block, but it's usually like, so renal osteodystrophy, it's like the kidney is causing your bones to have a dysfunction, basically. So basically it's chronic kidney failure that leads to bone disease. That's what renal osteodystrophy is. So just take this for what it is for now, because like I said, you're going to go into this physio when you get to endo. This is actually going to be a big portion of endo, is like understanding like the phosphate, the vitamin D, and the calcium relationship. But usually what happens is your kidneys fail, right? So they're sick. They can't excrete phosphate anymore. So you end up having hyperphosphatemia, so high levels of phosphate in the blood. Additionally, in kidney failure, kidneys actually convert inactive vitamin D to active vitamin D. This is just like a fun fact. You'll see it, again, when you do endo. There's like a nice picture in first aid, actually, and it shows like, here, you need the kidneys to convert this inactive vitamin D to active vitamin D. So if your kidneys aren't working properly, you have what's known as hypovitaminosis D, or just decreased levels of this active form of vitamin D. Vitamin D and phosphate. So vitamin D is very, very, very important for calcium reabsorption. Again, this is a very endo thing. But if you even take calcium supplements, a lot of calcium supplements have vitamin D, like supplemented with vitamin D, because you need both to like be able to even reabsorb calcium in the GI tract. So if you don't have vitamin D, coupled as well with elevated phosphate kind of like likes to bind up all the calcium it can. It just like finds calcium, it binds it. It's like, nope, you can't be reabsorbed because I want to bind to you. So if you have tons of phosphate and no vitamin D, you cannot reabsorb calcium. You just can't do it. So this is basically where kidney failure leads to hypocalcemia, so low levels of calcium in the blood. If you don't have calcium, I feel like it's like a what's that called? Like a caveman. Decreased calcium, bones not strong. bone lesions. But like literally, like your bones can't be strong if you don't have calcium. Again, you'll go into it with endo. But again, if you see like patient with renal failure and now they have a bone lesion, they're like, what happened here? That's renal osteodystrophy. It's because of these weird things with the phosphate and with the vitamin D that you can't reabsorb calcium, and it's leading to all sorts. This is not the only thing that happens when you don't have calcium. There's lots of manifestations of hypocalcemia, which you'll get into with endo, but this is what renal osteodystrophy is. The bones get all weird because of the kidneys. Okay, so I thought that deserved its own slide. It's really cool, but you'll go into it more. And then this is your mnemonic for consequences of chronic kidney disease. These were all listed on your, it's like Genora found this mnemonic and listed all of them on your syllabus. And a lot of these can be explained, again, just think of the kidneys just being sick. So you have a metabolic acidosis. It's an anion gap metabolic acidosis. So sometimes you'll see like AGMA and NAGMA. If you haven't yet, please go look at like, how do you calculate anion gap? What are the anion gap causes? What are the non-anion gap causes? So anion gap metabolic acidosis, this mnemonic, if you use the one in first aid, is mud piles. Non-anion gap metabolic acidosis is hard ass. So this is actually, like if you look at the mud piles for anion gap metabolic acidosis, U in mud piles is uremia. So that's kind of like, that's, yes. And we'll go into that a little bit, but it causes a metabolic acidosis. So I'm going to talk about all the ones that make sense because the kidneys themselves are just sick. So your metabolic acidosis, you can't reabsorb bicarb, you can't excrete any additional potassium, so you have high levels of potassium. You also can't excrete sodium, so you have high levels of sodium. Renal osteodystrophy we talked about. Erythropoietin, so EPO, this is what allows your red blood cells to develop. So it actually comes from the kidneys. So you'll go into this again, like I said, with hem-onc, but it's going to present as an anemia in the questions. If you don't have EPO or erythropoietin, you can't grow your red blood cells. Okay. Question, why is it only AGMA, not NAGMA? So anion gap, so if you remember anion gap is basically like all of the anions that are in your blood, if they have all of the acids that are in your blood, they usually have associated anions. Uremia has tons of, since you can't get rid of these nitrogenous waste products, you have tons of acids that you're not going to be able to excrete, and they have associated anions with them. So just for context, anion gap metabolic acidoses, uremia is one of them because of the acids that it can't excrete, and it's like they have those associated anions. Diabetic ketoacidosis, when you have keto acids, that's an anion gap metabolic acidosis. Lactic acidosis, if you have lactic acid buildup in your body, that's an anion gap metabolic acidosis. It's more of like a true like acidic cause that's causing that elevation in anion gap rather than like, the body's just holding on to chloride or it's just doing something else. That's one of those hard ass causes. And even like, we'll talk about this in a little bit, but like if you have ethylene glycol poisoning, so if you drink antifreeze for whatever reason, you just want to drink antifreeze, that its metabolite, ethylene glycol's metabolite, has associated anions with it. So that's also in the mud piles mnemonic. So everything that's in mud piles are things that increase your anion gap because they're acids that have associated anions with them that are going to just increase that gap. And we can go into this, anion gap versus non-anion gap. I think it's easy to kind of visualize it, but that's why you add up to calculate it. You add up all the, the main cations, and then you subtract out all the anions, and you see if there's a gap. And if there's a gap, that means there's extra acids there that are taking up that other side. Is that making any sense? I don't know if that's making any sense, but that's basically like it. Just memorize your mud piles and your hard ass. But just be able to calculate anion gap, and just keep in mind that uremia is one of those things that has all these associated acids with it because you can't excrete it through the kidney, and then you get this high anion gap metabolic acidosis. Okay. So we've talked about uremia, why that happens with these consequences of CKD. I don't actually know why you get like a developmental delay. I don't know if they just needed a nice G. I have no idea about this one, so this might just have to be a memorization one. It's not even in first. It's not anywhere. I have no idea why this leads in. There's some endocrine hormones that if you don't have those when you're born, like if you have like hypothyroidism when you're born, that can lead to developmental delay and like growth retardation. But I couldn't think of why for uremia. And then dyslipidemia, this is, oh, we have a, cool. So I think it has to do with phosphate and its interaction with VD. What's VD? That makes sense. Phosphate does a lot of, oh, vitamin D. Ah, that could be. That's good. Yeah, so it could be with phosphate and its interaction with vitamin D. It could be, yeah, it could just be because of that hypocalcemia too. Yeah, you're absolutely right. That can definitely cause developmental delay. Awesome. Yeah, so it's still a good G. It's still a good G in your mad hunger mnemonic. But and then the other one is dyslipidemia. A lot of the times when you're uremic, you have like problems with insulin, like you'll have some insulin resistance, and then you'll see when you do GI, like insulin and lipid breakdown kind of go hand in hand. So you'll just have like weird symptoms with hyperlipidemia, dyslipidemias kind of occurring. And this is like the last thing we'll talk about today are the dyslipidemias. But for the most part, if you see some of these in a question stem and they're talking about, like, it kind of sounds like this patient can't like reabsorb things and has problem excreting other things, maybe think about chronic kidney disease. But this is all the consequences that were listed on your syllabus. So my guess is it's going to be like mentioned in a vignette, and you kind of have to figure out like this is how chronic kidney disease presents with some of these. Okay. All right. So next is micturition. So before we can talk about incontinence, we have to go over the micturition response. Like I said, this is very, very, very neuro heavy, super neuro heavy, but we're going to talk about it a little bit in terms of like, I tried to make it as most relevant as possible. But the micturition center, it's located in the pons. The pons is a part of your brainstem. So it's not truly in the brain, it's in like the brainstem. So micturition itself, so people are like, well, what's the difference between micturition and urination? Micturition is involuntary. The act of like actual voiding or urination, that's voluntary. So micturition is going to be everything that's happening to the bladder that you're not doing. You're not sitting there being like, all right, bladder, contract. Well, maybe you think you are, but you're not. You're actually not controlling that process whatsoever. That is the micturition response. You're only controlling down here, this actual release of urine at the very, very bottom. You're actually only controlling the external sphincter. So I tried to go through this image, like I tried to go through this first aid picture. So basically, very quick anatomy of the bladder. You have what's known as the detrusor muscle. So you have this detrusor muscle. This is the muscle of the bladder. Then you have an internal urethral sphincter and an external urethral sphincter. And if you notice the nervous control, you have parasympathetic and sympathetic control on the detrusor as well as the internal urethral sphincter. If the parasympathetic and sympathetic nervous systems are involved, that's autonomic. Autonomic means you don't have control over that. It's completely involuntary. Like, again, when you're exercising, you are not telling your nucleus tractus solitarius to release epinephrine. You're not doing that. It's just happening on its own. So this control up to this point is completely involuntary. That's more of like your micturition response. Okay, and you can see the receptors. I listed the ones that were certain G protein coupled receptors. So like M3, this is a GQ. It's located on the detrusor muscle. Beta 3, I looked into this because I was like, I don't think that's a GPCR. I looked into it. It's like technically it's in the GPCR family, but no source I could find could agree on what type of like G protein it uses. So we're just not going to worry about it. It doesn't matter. So that's beta 3. And then on your internal urethral sphincter, these are alpha 1 receptors, and these are the same alpha 1 receptors that are found on your, like in your veins and in your arteries. Okay, so we have M3, beta 3, alpha 1, and if you can notice, parasympathetic innervation goes to the M3, sympathetic goes to the beta 3 and to the alpha 1. So this is all involuntary up to this point. And then the actual voluntary part of this whole process is the external urethral sphincter. So this is like when you're like, I really have to go to the bathroom, but I'm not going to obviously pee right now in this car until I get home. You are contracting your external urethral sphincter. This is somatic input. Anytime you see somatic, this is voluntary. So like you have control over it. And the specific nerve, and these are the specific nerves that do it, but it's more so understanding that what does parasympathetic input do? What does sympathetic input do? What does the somatic input do? Okay, and we'll go through this in a little bit more detail. But basically, micturition, it's like this coordination between sympathetic and parasympathetic. You can't have both firing because they're both trying to do different things, right? Because one, sympathetic is fight or flight, like you're running from a bear, you're ready to go. Parasympathetic is like you're about to go to bed and you're super relaxed. So you can't have both of these happening at once. So micturition is like this coordinated response between the two. So like I said, if you're running from a bear, you're not trying to pee. So they say like if you sympathetically stimulate the bladder, you are increasing urinary retention. You're not going to go to the bathroom. You're not going to void. Parasympathetic, it's like you're super relaxed, you're chilling, you're like, this is your rest and digest system. This is where you can now actually void. The actual process of voiding is very parasympathetically oriented. And we'll talk about like why right now, actually. So I made this chart for you guys. So this is, again, micturition. What happens with micturition? So it's kind of confusing in terms of like, oh, well, if you contract this one, but relax this one. Because like I said, it's this coordinated control between sympathetic and parasympathetic. So what I was trying to do here was like to actually micturate, which is like, you know, if you are undergoing micturition, you're going to go to the bathroom eventually. You're going to void. So micturition, you need contraction of the detrusor muscle. So you need contraction of this muscle. And you need relaxation of those sphincters. Hopefully that makes sense. We need to contract the urine out of here, but we don't want to block it here and here with sphincters blocking it. So this needs to contract, but these two need to relax. Okay, so that's micturition. If you don't want to, like you're not trying to void, you would want to do the opposite. You'd want to contract those sphincters because you want to keep everything in the detrusor, like where the detrusor muscle is, and then you'll allow the detrusor muscle to relax. So relaxation of the detrusor muscle kind of like allows urine to kind of like stay there, like a nice little pool. You're not trying to contract it out, like get out of here. It's like, okay, you guys, yeah, sure, you can stay here. So basically the sympathetic and parasympathetic control, if it's like voiding, not voiding, it's kind of like which of these is it trying to do? If you're trying to void, again, parasympathetically controlled, all of the receptors it binds to is trying to do these functions. Contraction of detrusor, relaxation of those sphincters, okay? So in terms of like these things, so I didn't even put like the actual nerve that's here. I think it's, again, more important to understand this like big picture. So sympathetic, you're not going. We are not voiding. We're no-go. Sympathetic's no-go. So when you have sympathetic nerves binding to the beta-3 receptors, which are located on the detrusor muscle, you'll get relaxation of the detrusor. And remember, relaxation is a no-go. You're not trying to micturate. Sympathetic stimulation on the alpha-1 receptors, which are located on the internal urethral sphincter, that's contraction of that sphincter. So you'll get contraction. And again, a lot of the times when you stimulate alpha-1, you're going to get contraction. Parasympathetic binds to M3 receptors, which are located on the detrusor muscle. And if you understand that parasympathetic, it's like you're trying to go to, like we're trying to void, and you're binding to receptors on the detrusor muscle, it's probably going to be contraction, which is what happens. And then somatic, something to understand, somatic, you're not trying to go to the bathroom normally. Like it's kind of like, it's like a conscious decision, like, oh, I have to go to the bathroom. You don't just sit there and you just start peeing. That just doesn't happen. So normally it's like a no-go. Like you're just normally like not trying to contract your external urethral sphincter or trying to relax it. It's like normally like not. So what happens is your somatic nervous system basically activates these nicotinic receptors located on the sphincter, which is going to contract it because this is normally what happens. When you want to go, that's when you basically are sending signals to not bind to this nicotinic receptor so we don't get contraction. It's a very like you are doing that type thing, but normally it's like we're not going all the time. All right, so that's micturition. So hopefully that helps with understanding what's going on here with these incontinence things. So again, the 3 that were listed on your syllabus, but incontinence in general is basically when urine leaks out involuntarily. Again, you're not trying to go to the bathroom and involuntarily you just start leaking out urine. So this is common in older individuals. A lot of the times, I mean, we've all heard of adult diapers. This just happens as you age. And a lot of the times it's in women more than men. Not saying men can't have it, but it's in women more than men. And then the 3 types I'll talk about is stress, urge, and overflow. I think it's on your syllabus as urgency. It's the same thing. It's just I call it urge incontinence. So stress, urge, and overflow. So stress, the underlying mechanism is stress. So it's usually when you have some sort of urethral, so the urethra is like where urine leaves the body. You have urethral hypermobility. So a good example of this is women after they undergo childbirth, lots of stuff happens in there, and it's just like now it's like not as nice and compact. It's like very just it's more mobile now. Yeah, so you can also have an intrinsic sphincter deficiency, and it's not like it's missing, like deficiency is a strong word, but it's kind of like it doesn't do what it's supposed to do anymore. It's not really contracting if you're not trying to go to the bathroom, and that can just be aging, it can be obesity, it can be trauma, it can be anything. Or you have some sort of increase in intra-abdominal pressure. So increase in abdominal pressure, like you're laughing, you're sneezing, that adds to increased pressure in the bladder, and that increased pressure is greater than the resistance to flow from those two sphincters. So again, how many of, like if you've ever sneezed and like a little bit of urine came out, that technically is stress incontinence, technically. So clinical features, they'll literally do that. They'll do a stress test. They'll call it a urinary stress test, and they'll just make you do like Valsalva, or they'll make you cough and then see if you have leakage. And again, they're just trying to raise that intra-abdominal pressure. Usually there's really no treatment for this. You just do pelvic floor exercises. Can stress or anxiety cause stress incontinence? Good question. So stress itself, like it technically can because, well, so stress is a sympathetic response, right? So a lot of the times with the sympathetic response, it's actually like the opposite. It's kind of like a no-go signal. So it's really not like stress itself or anxiety itself causing that micturition response. It would actually do the opposite, but it's more of like stress to the area. So again, like that abdominal, like not abdominal, sorry, like urethral issues, like increases in abdominal pressure, that type of thing. But usually I would expect stress to have the exact opposite response on this. That's a good question because stress messes with you a lot. You'll learn that in GI when you get to GI. Like stress actually really messes with your GI system. So urge incontinence, this is like literally urgency. If you ever heard someone say that they have urgency, it's usually an inflammatory cause, so like a UTI, or it can be something neurogenic. Again, you'll cover this in neuro, what those neurogenic disorders are, but it basically can lead to a bunch of different stuff. Just having this inflammation of the detrusor muscle, it can lead to sphincter dysfunction, it can lead to detrusor overactivity, it can just lead to overactive bladder. But it's because of this inflammation, you're getting autonomous. So again, remember, autonomous is involuntary. You're not doing it. It's just randomly contracting, like when it's not supposed to be contracting. Like we're not trying to do a micturition response and it's still contracting. That's why people feel urgency. They feel like they have to go to the bathroom. They're like, oh my God, I have to go, even though they're like not trying to. So clinical features, they have this strong sense of urgency followed by leakage. And then the treatment, this is kind of where understanding those receptors comes in. So treatment, you give a muscarinic antagonist. So remember, a muscarinic antagonist is going to block the M3 receptors on the detrusor. And again, on the detrusor, if you have parasympathetic activation, which usually activates these M3, that's what leads to the contraction. Now we're like, let's block that. We don't want parasympathetic activation on M3. We're just going to block that, and then hopefully it'll relax it. It'll help relax it. And I gave you a name of a med. I'm like medium on like knowing these because again, they weren't on your syllabus and your exam's 1 week away. But just in terms of like looking in vignettes for drugs, it's good to kind of start learning the drugs. But this is an example. Oxybutynin is like the name of an M3 antagonist. You can also give a beta-3 agonist. And remember, beta-3, this is a sympathetically stimulated drug. And remember, sympathetics, no-go, which is good. So if you block beta-3, if you activate beta-3 receptors, because this is a sympathetic receptor, hopefully you're not going to go because sympathetics is like, no go, don't go. And examples like mirabegron. And then the last one's overflow incontinence. I'm going to say right now, you're going to do this again in neuro. There's like a classic spinal cord lesion that leads to overflow incontinence down here. So you will do this again in neuro. But the underlying mechanism is basically like the detrusor itself can't contract properly. So you can imagine it's almost like you're waiting until like the urine builds up so much that it just flows out because it's like you can't wait for the detrusor. It can't contract. So a lot of the times, as you can imagine, it's a lot of neural stuff. So it's like you have like neurogenic bladder. It's like you have like all the nerves that lead to eventually contracting your detrusor are just kind of like not working. So neuropathy I thought is the most at least relevant for this block, but it's just kind of diabetes can cause like lots of stuff. So diabetes can cause neuropathy, which can again lead to like the detrusor not contracting properly, and then it can lead to polyuria. So it's just like tons of urine, but it's just all coming out like all at once because, again, the detrusor can't contract. Or, and this is where like it kind of comes in with men, is bladder outlet obstruction. So you have like benign prostatic hyperplasia, your prostate gets really big. The prostate sits right in like where the urethra is, it sits right there, and it can actually obstruct flow. So those are the two mechanisms. It's either the detrusor itself can't contract, or there's like an obstruction, so like urine can't get out. But eventually it will, and that's when you get this overflow. But both of them is like the bladder itself can't completely empty, again, because it's like it can't contract, like the detrusor can't contract. So the bladder overfills, and then you get this chronically distended bladder. You have tons of pressure, and then it just kind of like leaks out. So they call this dribbling of urine. So it's kind of like, and if you've ever heard someone that has BPH, they'll say like, oh, the urine dribbles out. But that's like what happens. It's like leaking out because it's like the detrusor can't contract. So it's kind of like, all right, let's wait until we have tons of urine in here, and then it'll just eventually just flow out. It just has nowhere else to go. Okay, and then, so clinical features of this is like, so overflow, any of those causes, so BPH causing it, any of those neurogenic causes. This is just frequent, involuntary, intermittent, continuous dribbling of urine without an urge to urinate. Again, it's kind of like there's no urge to urinate because the detrusor muscle can't like work. So it's like you're only going to go to the bathroom when the bladder is completely full. So that's where it gets the name overflow, because then it can kind of like dribble out. It can occur with changes in position, again, because you can help like gravity kind of help. And then even after you void, you're going to still feel like you have urine in your bladder, because you probably do. Again, the detrusor can't contract, so it just kind of stays there. And then how do you treat it? So you want to try and help with voiding. So imagine activating parasympathetic, inhibiting sympathetic. So you give an alpha-1 antagonist. This is like a classic drug you give for BPH because of this because of this overflow incontinence. So you block alpha-1, it should relax the internal urethral sphincter. And then in general, if your detrusor muscle just isn't contracting, you can give a muscarinic agonist. So M3, this is on the detrusor muscle. It's parasympathetic. You activate it, it's going to help with voiding. So here's kind of like, again, a kind of every single thing we've talked about. This is just like a summary slide. You can go through it after, but then all the indications, like why would I give something over something else? And hopefully it'll like make sense. I tried to color code it so it can help. And then this is like a nice picture, because again, these are the 3 types of incontinences, and you can see that there's a very big, like not a big difference, but they obviously are like 3 different underlying pathologies. All right, so kidney stones, I know there's a lot of slides on kidney stones, but it'll be quick. I just wanted to show you pictures. Basically with kidney stones, this is when urinary solute precipitates out as a stone. So I honestly think of kidney stones as like dehydration of like your kidneys. So it's kind of like you have high concentrations of a solute, like relative to water in there. And not only that, you have very, very low urine volume. So it's going to be very, very concentrated. And then it can just like concentrate out as a stone. And how it's going to present, so this is like what you should look for in question stems. This colicky pain, they'll mention colicky pain a lot with like GI pain. It's like it kind of like comes and goes. The actual like term for it is waxes and wanes. It comes and goes, like whatever. Hematuria, because you can get like bleeding. So hematuria, blood in the urine. Unilateral flank tenderness. So flank usually means like lower back. That's like flank pain. So remember from your SAD puckers mnemonic from anatomy, the anatomy session, ureters are technically retroperitoneal. So you'll see back, like low back pain, because that's like, it's a retroperitoneal organ. So you'll actually feel back pain. And then this is usually this is the one that doctors test for. This is what you'll learn when you learn how to do like I don't even know. Like I think it's a part of the GI exam. Or it might be in I don't know. But you'll do that. You'll do a test for CVA tenderness. So costovertebral angle tenderness. You literally get you make a fist, you put it on like where the rib cage, on the back where the rib cage is, and you just hit it. And you're like, all right, does that hurt? That is, if it hurts, that's CVA tenderness. And you're like, oh, that might be a kidney stone. It's like a kidney stone test. Usually the stone passes on its own. You can also like shoot sound waves at it. They call that sonication. You just shoot. It's like you use an ultrasound machine and you shoot sound waves at it, and then it helps break the stone, which I think is really cool. Or you can just surgically remove it. A lot of the times the stones like look the same on x-ray, so they'll look at crystals to help you identify what type of stone it is. another chart. I really like charts. So these are the main stones, I think. So we're going to go through these very quickly, and then I have some pictures. But calcium oxalate, phosphate stones, these are the most common types of stones. So it's like whenever in doubt, and it's like, what type of stone does this patient have? It's probably calcium oxalate. It's very, very common. It's going to form in the urine if there's an acidic pH. Usually it's present in adults, and it's radiopaque. So radiopaque is like you can see it on x-ray. It's opaque. It's very like it's like white on x-ray. Causes is like, for whatever reason, idiopathic hypercalciuria. You have increased levels of calcium in the urine. And sometimes it's because you have elevated calcium in the blood. Sometimes it's not. It's like a totally different cause. So you have to rule out just having high levels of calcium in the blood. And you have to rule that out. You can also have this with hyperoxaluria. Why acidic pH? It's just like they noticed that this is where these calcium oxalate, like that's where these crystals tend to form, is in more acidic pHs versus like, for example, phosphate is made up of a bunch of bases, so they will form in alkaline pHs. Uric acid is an acid, it's going to form in acidic pHs. So it's just kind of like the type of pH that would allow precipitation of those solutes. A lot of the times the pH is like normal, it's just like more acidic than basic. Another thing that I think people forget about calcium oxalate stones is it isn't just having high calcium in the urine that can cause these stones, it's also having high levels of oxalate. And oxalate can come from antifreeze. So remember, antifreeze now is causing an anion gap metabolic acidosis, and can also cause calcium oxalate kidney stones. So antifreeze, it's ethylene glycol. That can cause too much levels of oxalate in the urine. Too much vitamin C. This one always gets me. So if you're one of those people that takes like 6 vitamin C tablets a day, you might have calcium oxalate stones. It just increases the amount of oxalate in your urine. And then Crohn's disease. I only put this on here because like it might come up next block, and you're like, okay, like I remember. You treat this with thiazide diuretics. So my question to you guys is why? And I'll let you like ponder for a second. But just think about this, not the side effects of thiazide diuretics, but what thiazides do. So they actually cause reabsorption. Yes, amazing. So they cause reabsorption of calcium. So everyone's like, well, why? Like, how does that make sense? Remember, what's causing these stones is calcium in the urine. So even if these patients have hypercalcemia, you want to get calcium out of the urine into the blood, and then you can deal with it later. So you can give a thiazide diuretic literally for this hypercalciuria. Not for hypercalcemia. It's not going to do any. It's hypercalciuria. You can get it. You're like forcing it to go into the blood. You can also give thiazides if someone has hypocalcemia, so low levels of calcium in the blood. You can give a thiazide and be like, all right, well, reabsorb more calcium. Just reabsorb more from the urine. And that's like the other way that you can. So it's like you can give thiazides for like these endocrine issues as well as, being diuretics. And then a lot of the times they want to hydrate you because, again, remember the problem is like not making enough urine. So it kind of like everything's stagnant. It kind of just stays there. And then these stones precipitate. So you hydrate them. And also you do like the opposite of what type of urine they have. So if it's an acidic urine, you alkalinize the urine. You give like an alkaline substance. Usually it's potassium bicarb. And you just give it to them. And that should hopefully break because, again, these stones need this pH. So if you make the pH higher, those stones will break down. The next stone, these are triple phosphate stones, so ammonia, magnesium, and phosphate. That's the triple in triple phosphate. This is the second most common. Again, if the name didn't give it away, these form in alkaline pHs. They're radiopaque, so again, you can see them on X-ray. This is going to be infection with urease-positive organisms. There are a lot of urease-positive organisms, but I'm telling you, when they ask about this type of stone, they're probably talking about this bug called Proteus mirabilis. So Proteus mirabilis, and again, not the only one that forms urea, but basically what they mean by this is protease makes urea. So urea, super basic. So it's kind of like, and again, Proteus is like, it's in the the urinary tract. So you're making urea, you're making these super, super basic compounds in the urine in an already alkaline pH. You're going to precipitate with a stone. You can also just have, so that happens. So you'll see like these stones, but they can also precipitate what's known as struvite stones. Struvite stones are just the type, like this is the type of stone that forms from this alkaline urea, that forms from just having tons and tons of urea. They call it struvite. And then struvite, if it gets just massively large, they call that a staghorn calculus. And I have a picture of it. It's like they're insane. They took up the entire size of the kidney. They're massive. You have to take them out with surgery. And then you treat the Proteus, obviously. And then you hydrate and you acidify the urine. You give like an acidifying agent. And then uric acid, this is the third most common. The important thing to understand about uric acid, it has acid in the name, so you know it's going to be an acidic pH, but they're radiolucent. So I put like the U for uric acid and radiolucent. You can't see these on x-ray. So there's no way, if you do an x-ray and you see a stone, it can't be uric acid. Random stuff can kind of precipitate this, like hot, arid climates with an acidic pH. I don't know why. It just like kind of precipitates this. It probably leads to that further dehydration. But most common cause, so MCC, most common cause is gout patients. And patients with gout have tons and tons and tons of uric acid. And that's usually, you'll see like uric acid stones in gout patients. And same thing, hydrate, alkalinize. And then lastly, cysteine. These are very, very rare. These are usually only going to be in children because it's basically like an issue, like it's a genetic disorder. So you'll see them like earlier than adulthood. So these are going to form in the urine with an acidic pH, and it's caused by this genetic, it's called cystinuria, where the renal tubules can't reabsorb cysteine. This can form staghorn calculi, but it's going to be in kids. So if you see like a child with a staghorn calculus, that you're like, okay, that's probably like a cysteine stone. It's probably not Proteus that's forming urea. Okay, and then so I have pictures. So this is a calcium oxalate stone. This is a calcium phosphate stone. Calcium oxalate's the more important, like not the more important one, but if they were to show you a picture, they'll probably show you this one. And they say it looks like a biconcave envelope. So these are all the calcium oxalate stones. And so they're saying it looks like a biconcave envelope. It's like you have an envelope that way and you have an envelope that way. I drew that really weird, but that's calcium oxalate stone. This is a phosphate, monophosphate. You can also see calcium monophosphate. It kind of looks like this, but I'm pretty sure this is the one they would show you if they were to show you one. And on x-ray, it would look like this. Because here's like a stone, because again, they're radio opaque. So you can see them on x-ray, and then you would do like a urinalysis to see if you can see crystals, and that's going to tell you what type of stone it probably is. It's like very associated with these crystals. These are triple phosphate crystals. They said that they look like coffin lids, which is super morbid. But if you look at it, it kind of looks like it goes up like a coffin lid, I guess. Oops. So, like, this is a good one. I mean, they all look like that, but this is a good one to kind of see, like, the coffin lid appearance. So that's triple phosphate. This is your staghorn calculus. So these are, like, your struvite stones that form from that massive amounts of urea, and then if they develop over time, they form into the staghorn calculus. And calculus just means stone when you see calculus, that they're just talking about a stone. This is the stone. So it looks like it just outlines the kidney, and that's exactly what's happening. And then you take it out, and it's just like this 12-inch massive thing, and you're like, wow, this was in someone's kidney. So this is, again, probably, yeah, it's really big. It's really, really big. It's very obvious if you have a staghorn calculus, especially compared to, this. You're like, okay, it's like, this is a stag. Okay, like, all right. And they say it looks like, a stag, like those like antlers on a stag. That's where it got its name. But again, Proteus mirabilis, urease producing bacteria. There are more. Klebsiella is one. I just don't want to shoot out all urease positive producing microbes, but I think Proteus is one that's, ew, don't tell me it looks like ginger. I love ginger. All right, we're going to move on so I don't think about ginger. It does though, you're right. So these are uric acid. So these are uric acid crystals. They say that it has like oh my God, guys, stop. You're going to make me really sad. All right, well, okay, so these are your uric acid crystals. So it looks like, they say it looks like a rounded rhomboid, which, yeah, they're not wrong. So that's that. And then remember, you can't see uric acid stones on x-ray, so I have no x-ray to show you. But that would be like an example. And then here's like a cysteine crystal. So cysteine crystals look like hexagons. Again, this is going to be in like a child. It's going to be in like a 1 or 2 year old, and you're going to have like these hexagon crystals. You're like, okay, they probably have cystinuria. I see these hexagon crystals in the urine. They probably have cysteine stones, and they're presenting with flank pain, hematuria, that type of stuff. Okay. So next, and then basically I have, ooh, I love that, 16. I love that. The sides, right? I'm gonna feel really dumb if there's not 6 sides. 4, 5, 6, yay! Love that. 16. All right. I'm gonna steal that. I love that. Amazing. Perfect. So yes, your hexagon versus your rhomboid. Gotta do your geometry to do well in this exam, right? But okay, so then kind of finishing out with these kidney infections, and then I have like, a couple slides on the hyperlipidemia. Sorry, I really wanted to get everything in here for you guys before your exam. But so acute cystitis, this is an infection of the bladder. So cystitis is just cyst means like bladder, basically. It's just like a fluid-filled sac is what a cyst is, right? So they call the bladder, they're like, you know what? Yeah, the bladder is technically a fluid-filled sac. Let's just call it a cyst. So medical terminology, when you see cyst, think of like a fluid-filled sac. The bladder is cyst stuff. So acute cystitis is basically like an infection of the bladder. They call this a lower UTI because the bladder is considered lower than the kidneys. So we'll talk about pyelonephritis very briefly. That would be an upper UTI. But lower UTI, this is a bladder infection. This is like acute cystitis. It presents exactly how you would imagine a UTI would present. So pain during urination, dysuria, urgency, because again, usually UTIs cause that automatic contraction of the detrusor, suprapubic pain, so right above like the pubic bone, you would feel pain there, so really, really low down there. Usually with cystitis, so this lower UTI, you don't see systemic signs, so you don't see fever, you don't see like signs of inflammation, which is a big difference from pyelonephritis. Okay, so it's kind of like, even though, yeah, it's technically inflammation, it's an infection, you usually do not see systemic signs. And you just diagnose it with urine testing. So you do a urinalysis, the urine's gonna look super cloudy. There's like probably bacteria in there, there's white blood cells in there. So white blood cells are present, cloudy urine. You do a urine dipstick, so you dip a little thing in the dipstick, and you'll see a positive leukocyte esterase. Leukocyte esterase, it tells you leukocyte, white blood cell. The leuc in leukocyte, or leuko, means white. And then cyte is cell, so white cell. So you have a positive white cell. Esterase is just an enzyme that only white blood cells make. So it's kind of like, okay, like let's use that as a test to see if white blood cells are here. And if it's positive, that means white blood cells are there. Another test that they do is for nitrites. And nitrites mean that bacteria is present. So bacteria take nitrates that are found in the urine and they reduce them and then turn them into nitrites. And again, only bacteria do this. So if you have nitrites in your urine, that means bacteria have to be there. And then you can culture it. So culture is the gold standard. You literally take the urine and you put it on a plate and you see like what grows. Nothing should grow. Urine, again, should be sterile, just like blood. Blood and urine, both sterile. So if something grows, you're like, well, that shouldn't be there. So that's usually like indicative of a UTI. And this CFU, this stands for colony forming units. And this just means each colony is like one colony of bacteria. And you can imagine 100,000 of those on like a plate. That's like very indicative of a UTI. Okay. So your common causes. So your common bacterial causes is E. coli is going to be 80% of the time, it's going to be E. coli. What's a normal value for CFU? 0 in the urine. So you should have no CFUs in your urine. Sometimes you'll have some because they can attribute it to like when you take the urine, like when you have to do like urinalysis and capture it in the cup. Sometimes you get like just kind of like contamination from the process of urinating from just like the other structures down there. So when it's like a little bit of them, they're like, oh, it's probably contamination. I'm not too worried about it. Greater than 100,000, it's like that, those are in the urine and they should not be there. You should have technically zero CFUs in your urine. Yeah, no problem. So these common causes is E. coli is 80% of the time. Like if you hear someone has a UTI, your brain should be like, all right, it's probably E. coli. So sometimes they'll mention like young sexually active women, and that should put you on to Staphylococcus saprophyticus. So Staphylococcus, remember the gram-positive circular cluster of grapes because it's a staph. That is saprophyticus. It just lives. It's just like a normal staph that lives like in the genitalia. So a lot of the times they're like, okay, well, if you have a sexually active woman, like it can move from like the vagina over to the urethra, and then it can cause a UTI. But here is my little, you will get tricked. You will get got. I didn't put that on here, but don't get got from this. E. coli is still the most common overall. a lot of it, and I've done a lot of, micro questions in my time. They probably will still put that there's a young sexually active female, like a 25-year-old female, and it literally will say this woman is sexually active. And you're like, oh my God, staph saprophyticus, what? But a lot of the times it's still going to be E. coli because they're trying to get at what's the most common. And the most common is still E. coli. E. coli is still the most common overall, including young sexually active women. So a lot of the times if they want you to pick staph saprophyticus, like go out of your way to not think it's E. coli anymore, they might have to tell you something about the gram stain. So the gram stain, remember, staph species are gram-positive cocci. E. coli is the exact opposite. Gram stain's pink. It's a gram-negative rod. It looks like pink little rods like this, like little lines. That's how E. coli looks. So I feel like they would have to tell you something about this for you to go out of your way to pick staph saprophyticus because, again, E. coli is still the most common. Here are some other ones. Klebsiella, Proteus mirabilis. This is usually going to be, it's going to be associated with that staghorn calculus. And then Enterococcus faecalis. These are just like contaminants, again, they get from other parts of your body into the urethra. So what if you have symptoms and then you see sterile pyuria? So sterile pyuria, it's kind of like the sterile blood cultures with endocarditis. So sterile pyuria means there's no bacteria there, it's sterile. And pyuria, remember pyogenes, strep pyogenes, it's pus forming. Usually when you see pyuria, they're talking about white blood cells because white blood cells are the reason you get pus, usually. So pyuria means that there's white blood cells in the urine, but it's like there's no bacteria there. When you culture it, when you do the nitrite test, you're like, that's weird. Like, what's sterile pyuria? That is usually going to be due to an STD. So chlamydia or Neisseria. So another trick is they might say the patient had a previous Neisseria infection or like a previous like they had gonorrhea in the past or they had chlamydia in the past and now they have a UTI. Don't jump for that answer if there's not sterile pyuria. And the reason it looks sterile, you're like, well, aren't chlamydia and gonorrhea bacteria? They don't gram stain well at all. And this is something you'll go into probably in repro block when you start doing STDs. But chlamydia and Neisseria, they don't gram stain that well. They do, like you can get them to gram stain, but on like first look, it looks like the urine is sterile. It looks like there's absolutely no bacteria there. But there's white blood cells. So you're like, there's got to be an infection here. But again, don't get got if they say patient had gonorrhea and now they have a UTI. Don't automatically jump at that. It still just might be E. coli, honestly. It might just be going to E. coli. Okay, so then what if the UTI ascends? So now we're in the bladder, we're at a lower. What if it just like keeps going up? It's like, no, I want to go up to the kidneys. That's your pyelonephritis. So when they say pyelonephritis, this is going to be your kidney infection, your actual kidney infection. This is an upper UTI. Again, it's usually due to ascending infection from the bladder, from the lower UTI. A risk factor would be vesicoureteral reflux. That should say reflux, darn it. Reflux. I remember we had a case on vesicoureteral reflux when I was a first year. So I feel like that's still relevant. So if you have a patient with vesicoureteral reflux and now they have a kidney infection, you're like, oh, it's probably pyelonephritis. They probably have like a UTI that ascended now. So patient presentation is fever. So again, note the difference with like a lower, like a cystitis versus a pyelonephritis. There's going to be a fever now because now we went higher up. The flank pain is still going to be there. Again, kidneys are retroperitoneal. And then you're going to see these signs and symptoms of basically like infection. So leukocytosis, white blood cells are going to be present. You're going to see just tons of white blood cells everywhere, as well as those cystitis symptoms. So like urgency, dysuria, all that jazz. Common bacterial causes, you guessed it, E. coli. So E. coli is the absolute number one cause. And when they say like common bacterial causes, this means like it probably started as a lower UTI that you were like, it's whatever. It's like, I'll be fine. I just want to get through it. I don't want to get antibiotics, like whatever. And then it just keeps going up. And that's why they always say if you have UTIs, don't wait. Like literally do not let it sit. Be like, oh, like whatever, I'll handle it. Because it can go up and then it can go to the kidneys and cause kidney infection. It's not good. But a lot of the times it's E. coli. E. coli just likes to just go everywhere. So it probably started as a lower UTI that ascended. And then you have like the other two that we had mentioned that can also cause lower UTIs. These are just two of the more common ones that like to also keep going, that keep ascending. Okay, Lipids, very brief because a lot of this I had mentioned already in the anatomy session, evolution of an MI. So from clinical cardio, I'm going to talk about your hyperlipidemia signs. I already think I know what she's going to ask, just in terms of like what I think she means by this, hyperlipidemia signs. But remember, again, if you did not watch the re-recording of the anatomy, go back through it when I go through evolution of an MI. This is like literally like so hyperlipidemia causes this atherosclerotic plaque. And then when the atherosclerotic plaque ruptures, that's what causes an MI. And there's this evolution that happens. So like an evolution of like symptoms, time course, histology. So just kind of go back through that and watch that if you haven't. But very quickly, atherosclerosis, this is an intimal plaque that obstructs blood flow. So again, remember that there's 3 layers to your blood vessels. There's the intima, the media, and then the externa or the adventitia. The intima is the innermost layer. So that would be, if this is the blood vessel, blood's going in here, you would get a plaque basically within this layer. It would be like in between the intima and the media. So basically what has to happen first is you get damage to the blood vessel. So a lot of times it's hypertension, right? There's just tons of blood coming through here, shooting all sorts of ways, and it damages this. And then lipids are in the blood. And if there's a nice little divot for, some, like a nice little pathway into the intima, sometimes the lipids are like, cool, I'm just going to go in here and just chill. And that's when you get the developing of a plaque. It doesn't happen right away. That's what the evolution of an MI is. But that's basically like kind of what happens. But we'll talk about it a little bit. So it starts as what's known as a fatty streak, and then eventually it turns into a plaque. A plaque has a lipid necrotic core. So there's this lipid core, and it's made up of cholesterol. And then they say that there's a fibromuscular cap. This is just the definition of a plaque. So this lipid core with a fibromuscular cap. Okay, that's just what a plaque is. Usually it affects your large and medium-sized vessels. The reason why is, again, because you need some sort of damage, and a lot of the times these are the ones taking most of the blood, like most of that really stressed blood volume. Risk factors are going to be modifiable, non-modifiable. I put them in the notes, like at the bottom, so you guys will see that in there. But modifiable risk factors is like, I have high cholesterol because I eat really poorly every single day, or I don't exercise ever, or I have type 2 diabetes and I just don't like take care of myself type of thing. Not saying that people don't take care of themselves that have those things. They can be completely familial. That's your non-modifiable risk factors. So modifiable is like what the American Heart Association has said, like you can change those risk factors, like you can modify them. Non-modifiable is like your age, you can't change your age, your gender, which I'll just leave that blank. But if you are a female at birth, you make estrogen, you make tons and tons of estrogen. Estrogen really, really decreases the risk of having atherosclerosis develop. That's why a lot of the times men have MIs. You don't really hear as many women having MIs. It's because they're protected from estrogen. Okay, so that's what they mean in terms of like you can't change that. It's just because of like estrogen versus not having estrogen. Okay, and then what's the other non-modifiable? Family history. So if you have a family history of having like high cholesterol, you can't change your family history. So that's what's meant by modifiable, non-modifiable. These are really important for boards. That's why I wanted to take a quick second to go through them. They're really, really important. They will just ask what's a non-modifiable, like they'll just give you a whole vignette on an MI and be like, give me like 2 non-modifiable risk factors. And you're like, oh, okay. So that's why I wanted to take the time now. But like I said, I go into this much more detail in the evolution of an MI. But very briefly, like I said, there's some sort of damage that occurs. You get lipids that start to leak in through that intimal layer. Then these macrophages come into the area. They gobble up those lipids, and then they turn it and they get like oxidized. It gets oxidized, and then these macrophages are what's known as foam cells. So they look like giant, like foam-looking cells, and that's called a fatty streak. And it's only until like then you get inflammation, you get healing, you get disruption of the extracellular matrix, you get smooth muscle proliferation, all sorts of things happen to the point where then eventually you get a fibrous plaque that forms. And when a fibrous plaque forms, that is again that lipid core plus that fibromuscular cap. Okay, so that's what they'll say here. Here's your necrotic core plus your fibrous cap. That is considered a plaque. This is a plaque. Versus this is just like these are just all fatty streaks. Okay. And then eventually it'll destabilize. That's when you get your MI. Okay. And then lipid disorders, a lot of the lipid disorders are, again, like they're going to be covered a lot in GI, but I wanted to talk about hyperlipidemia because that was the one on your syllabus. So this is when you have elevated blood lipid levels. And by saying blood lipids, it's total cholesterol, LDL, triglycerides. Okay. So, like I said, hyperlipidemia, you will go into this during GI. This is so for boards, this is technically considered biochem. So I gave you a video to watch when you get there on like all the familial hyperlipidemias. There's a really I really liked Dirty Medicine. He has a bunch of really cool videos for board studying. He gives you really nice ways to remember stuff. So this is like one of the most highly recommended videos I have in terms of like remembering stuff. It's this one. So you can watch that, but I don't want to say not to study it for this exam, but you will go into GI. And then Boards and Beyond goes through each one by one, but you should still have an idea of what all those lipids are. And I put this little note here, like we can totally do like a lipid metabolism thing during GI block because it's going to be a lot more important in GI block. But I just wanted to briefly give you, so hyperlipidemia is elevated cholesterol, LDL, and triglycerides. So what are those things? So cholesterol, this is a polycyclic steroid. Polycyclic just means these are ring structures. So here in orange, this is the ring. It gets absorbed through food, but it's also made in the liver. And there's this enzyme that makes it. It's called HMG-CoA reductase. And this is absolutely important to know because this is what statins, so like that drug that everyone takes, statins, like everyone with high cholesterol is on a statin. It blocks HMG-CoA reductase. And that's the point. It's trying to block the production of cholesterol that you're not getting through your food, that your body's just making. And that's like a very commonly asked question. What is the enzyme that statins inhibit? HMG-CoA reductase. So what does cholesterol do in the body? It's incorporated into cell membrane, so it's a part of your lipid bilayer. Throwback to like general bio. And it's a precursor of steroid hormones, bile acids, vitamin D. It's just a precursor for a lot of stuff. It gets reabsorbed via bile salts. You'll go into bile salt reabsorption in GI. And then when they talk about total cholesterol, they're not just talking about LDL, which is like your bad cholesterol. They're also talking about HDL, which is like your good cholesterol. Estrogen increases HDL. Again, why estrogen is super, super important in terms of like understanding how this, in terms of like how atherosclerotic risk changes. So we'll talk about both of these, but that's why you'll see like HDL-C, LDL-C. They're saying like your HDL cholesterol, your LDL cholesterol, because they're both types of cholesterol. And then here's just another kind of like just visual, because I think biochem is just so boring sometimes, just with all the pathways. So this is basically in the liver. It's only happening in the liver. You go from HMG-CoA to mevalonate, and then you go through a bunch of steps, and eventually you get cholesterol. This is what statins block, this HMG-CoA reductase. I would absolutely know that enzyme. And then HDL, it's the good cholesterol because it acts as a scavenger. It basically goes, like it scavenges. Just imagine like a scavenger. It goes to like everywhere in the body where there could be fats and it just grabs it. It's like, all right, we're just going to reuse this so it doesn't stay in the blood. I'm going to bring you back to the liver. Let's try and use it again. The higher the better. So I think normal HDL is like greater than 45. I could be wrong. But like if you have really high HDL, that's awesome. And again, estrogen, I think at baseline increases it to like 60 or 65. It gets elevated in physical activity and moderate alcohol consumption. The joke with like me and my friends first year would be like, oh, we gotta go get some drinks after class because we gotta increase our HDL. So it's like moderate alcohol consumption can increase HDL, physical activity, just things that are like healthy can increase it. And then the higher the value, the more protective you are against atherosclerosis. LDL is your bad cholesterol. This is like your high-fat diet, a familial, so like modifiable as well as non-modifiable, and some other risk factors that like stuff is going to come up in future blocks. And this is going to correlate with the risk of atherosclerosis. So this level increases with the risk of atherosclerosis. HDL level correlates with the how protective you are against atherosclerosis. So they kind of like exactly cancel each other out. And then this is going to be triglycerides. So this is elevated in obesity. It can be familial or other. Same as LDL. It's very similar to LDL, but they don't know yet how related this is to atherosclerosis. Usually if you have high triglyceride values, you get issues with the pancreas. You can get pancreatitis. So they don't really know how much this contributes to like fibrous plaque formation and stuff like that. So these signs of hyperlipidemia, like I said, I already think I know what they're going to do. They're going to basically give you these signs in a vignette, and you have to be like, okay, this is hyperlipidemia. And I tried to find questions that did that to show you. But there's skin manifestation, eye manifestations, GI manifestations you'll cover next block, but it's basically like everything you can imagine, like all the organs get really fatty. And then atherosclerosis, which we talked about. And again, this is directly from LDL, that plaque formation. All right, so skin manifestations, the first one, and again, they're not going to say patient has a xanthoma. They're going to describe what it is or sometimes show a picture. So a xanthoma, xan means yellow. So it's going to look like these yellow skin deposits like this. That's a xanthoma. It's basically just lipids that deposit in the skin and in the tendons. So a lot of the times you get these xanthomas because of extremely high levels of triglycerides and LDL. They leave the blood, they literally leave the blood, and then they go and deposit in tissues. If you were to take like a biopsy of one of these xanthomas, they would look like foam cells. And then places to find these, just notice that it could just really be anywhere. Literally, you can find these anywhere. So you really have to just kind of recognize it when you see it, and just like the location is not as important. But I highlighted Achilles tendon because they call this a tendinous xanthoma. It's on the Achilles tendon. It's where these xanthoma, like these lipid deposits, go to the actual Achilles tendon. So this is what they can look like on the skin. So they literally just look like these yellow looking plaque structures, and they're just like these little circles that deposit honestly anywhere in the skin. Okay, so that's what xanthomas look like. This is a tendinous xanthoma. It doesn't look as yellow, but it looks like a little plaquey looking thing that's in the Achilles tendon. If you were to take a histology slide of this, you would see foam cells, which again, those are those macrophages that gobble up the LDL and they get really big. But the main thing to look at on histology is these cholesterol clefts, they call it. So this should be almost like a buzzword for like, this is like a xanthoma, this is some sort of thing like that, because this is cholesterol. This is how cholesterol looks. So each one of these is like a cholesterol cleft is how they refer to it. Okay, so, and you'll see them usually together in like little groups like this. So these are all cholesterol clefts, and immediately you should be like, okay, this is probably like a xanthoma. The next one is a xanthelasma. So a xanthelasma, xan for yellow again, but now it's in the eyes. So, or it's not in the eyes, it's near the eyes. So it's basically a xanthoma near the eyes. So these happen bilaterally, so they're on both eyes. They're yellow flat plaques on the upper eyelids, and usually they're on the nasal side. I'll show you a picture, but it's like they're on this side of the eyes. So it's like this. So you have one here, you have one here. Idiopathic, they don't exactly know why. Some people get it here, some people don't, but it's associated with elevated lipids. Sometimes with diabetes, you can see these more commonly than not. Again, like I said, insulin messes with like lipid breakdown, which you'll go into a lot next block. So a lot of the times diabetes is associated with a lot of these. And commonly you see these in men and postmenopausal women. Postmenopausal women, no more estrogen. Estrogen completely drops off at the time that you have after menopause. You don't really make as much estrogen anymore. That's what causes hot flashes in like women that are going through menopause. So when they say like men and postmenopausal women, they're almost like you need to like consider them as the same being kind of thing. Okay, especially for vignettes and board questions, postmenopausal women, it might as well have just said like a man, because it's like you cannot think of them having any estrogen. Okay, it's just like a tip for doing questions. So these are xanthelasmas. Again, they're going to be on the nasal side and they're going to be bilateral. So here's one here in this guy. So the nasal side, the nose side, and here's one here in this woman. So they look kind of yellowish, but they're like these plaques that deposit on the nasal side of both eyes. And then this is something called lipemia retinalis. Lipemia retinalis is basically where, again, like I said, a lot of these manifestations, because the lipids are leaving the blood and then going elsewhere, this is where it can go up to the retinal vessels. And you can see that the normal retinal vessels are nice and red. They're nice and like thin looking. And lipemia retinalis is like they're white and they're white. That should just be the first kicker. You're like, all right, that's not normal. They shouldn't be white. They should look like this. So that's like the first indication that you're like, okay, that's probably because of fat. That's why it looks white. And then secondly, the corneal arcus. So the corneal arcus, you can also see this called arcus senilis or senilis. I don't know. I think it's senilis. It's the exact same thing, but if you're doing like questions and you see arcus senilis, it's just corneal arcus in elderly people. Okay. This is when cholesterol and triglycerides deposit in the eyes, literally in the cornea, in an arc. So it can be, so in this image, it's right here. This is the arc. So see this white thing right here? This is lipid deposition. Sometimes it's really bad and you can see it across the entire eye. This one's really obvious. So if you see like a thin white layer around the cornea in like a half crescent moon type looking thing, this is corneal arcus. Okay. All right, we made it. Um, so I have some, I'm so sorry. I hope none of you guys are planning on having lasagna later. But this was, I know, I'm so sorry. But this is how you get through these blocks. I know, I'm really sorry to do that to you. But can you tell? I can't tell. Oh God. Oh God. I hope you're not hungry for lasagna. I honestly can't tell which some of these are. Don't, no ginger. No ginger or Staghorn calculus. Someone make that, please. But okay, so I want to do some questions. More so, like, I don't even care if you guys get these right. I just want you guys to see how they word this stuff, especially endocarditis versus rheumatic fever. I really want you to like work through it and be like, okay, all right, so let's do some of these. And I'll give you like 90, 70 seconds. And you can chat me privately, please. And like I said, a lot of these we haven't talked about. We haven't talked about a lot of these. It was more so me wanting you to see how they would be asked in a question. Okay. So ready to go over this one? So this one is, hopefully you guys picked up. It was the exact same picture I had on the side. So this is going to be your xanthelasma, right? So bilateral lipid deposits. If we go through the vignette here, it's like this woman, can't really tell if that's postmenopausal. It's again, it's like the men in the postmenopausal thing is more like just like that's what it's more common in. It wouldn't be like a make or break on a test question. Yeah, you'll never have. Yep, you'll never have all of the. Actually, when I was taking some practice tests for STEP, you take like certain amount of practice tests. I kid you not, I had A through like L. I wanted to lose my mind, lose my mind. And STEP, I had a question. It was like A through L or A through M, and I'm like, this is insane. We're just gonna just blindly just pick one here. But yeah, hopefully your exam will only be 5. Yes, I know. It's kind of crazy. I was very shell shocked. It was like a culture shock having A through L or A through M. I was like, we're just gonna pick a random answer. But STEP does that, unfortunately. But your exam should only give you 5, hopefully, maybe 6. But I think when you see AMBOSS questions doing that, they're trying to mimic STEP. But okay, so they don't really give you much else in here. It's really just so more so understanding that these are xanthelasmas, and then it's like, okay, xanthelasmas increase LDL, right? Or increase, yeah, increase. These are hyperlipid. This is hyperlipidemia. So remember, with this, you have an increased risk of having coronary artery disease. Like remember, you get the plaques, you get yeah. So this was like a very second year ish question, but again, just wanted you to recognize like they might not give you anything in the vignette, but if you see the picture, you're like, okay, that's a xanthelasma. Okay, and that's kind of what they're saying here. These lipid deposits, there's some sort of underlying lipid disorder which would increase the risk for atherosclerosis. Remember, LDL increase is directly proportional to your atherosclerosis risk. All right. I'm sorry, super long question. I know, and this goes to G. I'm so sorry. Yes, I totally believe that this could be a question you would see on your exam for sure. They can just ask what's the most likely causal. So for this one, yeah, I'm not as much, I don't care as much if you guys know this, because again, we literally just covered these microbes today, right? So I'm gonna go through this one because I think I got an option for every single bacteria that's listed. So I want to go through this, but I want to go through like how I would approach something like this. So I see the image, I'm like, this is a splinter hemorrhage. Okay, so again, seeing another image of a splinter hemorrhage. Again, I'm not going to jump to endocarditis, but this is a splinter hemorrhage. Okay, so this is what a splinter hemorrhage looks like. We have like an older man, okay, blah, blah, blah. He's got like some non-specific symptoms. He underwent an aortic prosthetic valve replacement. So, aortic prosthetic valve replacement. Remember, what is the usual trigger for, remember those little buzzwordies I gave you? This would be like one of those ones, but you can just keep it in the back of your mind, like, okay, going through, he did a colonoscopy and it was normal. Which one would that cross off? That would cross off the one that is only present usually in like your colon cancer patients. And then it just keeps going down, and then they kind of go into his vitals. He has like this murmur, so he has a murmur heard over the left sternal border. This sounds like a mitral regurg type thing, and it radiates up. Yeah, this kind of sounds like this. Yes, so you guys are kind of starting to get it. Good. Yeah. So splinter hemorrhages. He sounds like he's got like a non-specific signs of inflammation. He has a murmur, and he had a prosthetic valve replacement a few months ago. So 3 months ago. So this is going to be your staph epidermidis. Again, I know we just covered these. I just wanted you to see it in the context of like getting a question. They just list a bunch of microorganisms. So, for these other ones to have been correct, strep galolyticus, remember this is bovis. This is going to be the one that's only going to be present if the patient has colon cancer. Again, don't want to say only, but for vignettes, yes. Strep pneumonia, we did not talk about this. We did not talk about this one. This is the like most common cause of pneumonia, and he does have like some signs that some people are like, oh, maybe he has pneumonia, but this prosthetic valve placement, this is endocarditis, not pneumonia. Out. Staph epi we'll come back to. Enterococcus, this is just like another one that can cause it, but nothing really is indicative of this. We'll just skip it for now. Viridin strep. This is the one where you need a previously damaged heart valve. And I'm telling you, they're going to say something about him going to the dentist or having some sort of dental something. So out. Streptococcus pyogenes. A lot of you guys picked this one. This is for rheumatic fever. So I don't know if you guys confused rheumatic fever or just confused, like you knew it was endocarditis, but then just forgot the organism. But remember, rheumatic fever is going to be your strep pyogenes. This is your group A strep. This is your sore throat, and that'll always be in the vignette. Okay. Oh, so I thought you said staph epi is soon after. Yeah, so like within a few months, like up to a year after is going to be staph epidermidis. When I said like much later, that's like viridin strep can do it, but it's going to be like 1 to 2 years later, like much, much later. Oh, I gotcha. Yeah, so relatively soon after is like months, like up to like a year, I would say. And that's usually going to be your staph epidermidis. It's a good question though, because get it wrong now, right? Don't get it wrong on the exam. But does that make sense? I just really, again, wanted you to be like, okay, this is endocarditis. This is not acute rheumatic fever. They present very similarly, but there's going to be these little things in the vignette that you're going to be like, okay, this is, and notice this one didn't give you any like Osler nodes, Roth spot. You didn't get any of that. You just got some splinter hemorrhages. And I think they really wanted you to pick rheumatic fever for this one. But prosthetic valve, it's too good. Also, we have like an older man. I tend to not use age and like sex. I try like if it's a male or female or 63, like I tend to not use that. But a lot of the times acute rheumatic fever is going to be in a child. Not always, but usually it's going to be in a child. So if all of this is kind of leading to like endocarditis, which is usually going to be like in adults, that's just like another point for that. Okay. So again, it's a tricky one. Viridin strep. So remember, viridin strep, it's like there has to be a pre-existing damage. And this is kind of where it's, okay, so greater than a year. So viridin strep can cause prosthetic valve endocarditis greater than a year after. Okay, so then these are all in here. You guys can read through these. So I gave you the reference ranges because you will get reference ranges on your exam. I had one of the second years I tutor say that they didn't know that there was reference ranges on their exam they just took, and I was like, this is like your 8th exam. Like, you should know that you get reference ranges. So I just want to remind you guys, you will get reference ranges. You get reference ranges on boards. You get reference ranges on your exam. Is there a log button on the exam? I don't think so. But if you're talking about like the cardio equations, I don't know that you will have to do that. But yeah, don't worry about that. I don't think there's a I can't remember now if boards gives you a calculator. I don't think you get a calculator on boards. Your mental math. It's honestly like trickier for when you're doing biostat stuff, which you'll do second year. But biostats is like, I do like 2 plus 2. I'm like, I want to make sure that's 4. But so like biostats where it's like really involved, like more involved math. There's like tricks for like doing stuff, which you'll do next year. But I don't think you need to do like that type of math. So I'll give you guys a few more seconds because I was talking. Okay. So let's go over this one. So this is clearly a stone question. So this is how it presents. So left flank pain radiating to the groin. That's like classic. That's a stone in the ureter. And then they go through like other stuff like hematuria, so blood in the urine, blah blah blah. He's on a multivitamin, whatever. And then he's got CVA tenderness. That's a stone sign basically. But we know it's a stone because of the options. So then we look at the answers, and on first glance, it's like, okay, everything looks great. He just has hematuria. And then they do a CT scan, and you see a stone in the left distal ureter. So blah, blah, blah. They're doing all this stuff. So then he passes the stone. So when it's like metabolic analysis of the stone is most likely to show which of the following. So this answer is E. This is calcium oxalate. 1, it's the most common stone. 2, it's a little trickier, but he's on a multivitamin. So, I mean, it's such a small thing, but it's like, oh, maybe he's on vitamin C, I don't know. But the other thing too is like he's got acidic urine, so you can cross off this triple phosphate because you need alkaline urine for that. Xanthine we didn't talk about. I personally don't think it's super important to know xanthine. That can be like something you do second year for boards, but like normal pH of urine is like 4.5 to like 8. It's like the very wide range. So you look at, is it more acidic or is it more basic? So using 7.1 as like the normal, just like with blood. Or is it 7.4? I think 7.4 is blood. But I actually think it's 7 or 7.1 for urine because it's so much more acidic. It should be so much more acidic than basic. So I think it's like, yeah. So like 4 to 8 is normal. But again, so then cystine, that's kids. This is a 31-year-old. He has no issues. Okay, out. And then we're between uric acid and calcium oxalate. In theory, it could be either. Because remember, like calcium oxalate, the trick here is, remember, you don't need to just have elevated calcium. It can also be elevated oxalate, which can come from all sorts of different stuff. Vitamin C, for example. So for this one, it was really important to remember uric acid stones. Yeah, the normal calcium is tricky. That is very tricky. But remember, and I like this question because it's like it can be calcium, but it can also be oxalate. So that's either one of them can cause that. But for this one, remember, uric acid will not show up on imaging. It's radiolucent. CT scan, X-ray, you can't see it. So that's why it was kind of like, all right, this is probably calcium oxalate. Could it be that serum calcium is normal, but urine calcium is high? Yeah, that can also 100%. That can all. Usually though, like this is just ruling out that the hypercalciuria could be because of hypercalcemia and it's just kind of leaking into the urine because you have so much in the blood. But yeah, that also can totally happen. You really don't know until you see the calcium levels, but if you of the urine. But if you have hypercalcemia, like high calcium in the blood, you can almost be like, okay, it's probably hypercalciuria. Like you can probably like just make that jump. Okay, awesome. So that was that. And then I love the little Amboss physician comment. This is the most common type of kidney stone. Nice, thanks. Like really helpful. But it is. It's like 80%. It's kind of like the UTI with E. coli thing. It's like, okay, this is the most common UTI type of thing. But they talk about it here, and I think they mention, yeah, he's on a multivitamin. So they're like, oh, he's on a multivitamin, vitamin C, and I'm like, that's so silly. But just yeah, when in doubt, it's like the most common. And then the other ones here. Okay. So some of this I gave to you in the prompt. This, by the way, is like exactly how I think they would ask a question like this on your exam, just personally. This is like what I think. All right. So I'm gonna go over this one, just because I don't want to keep you guys here forever. I'm so sorry. But basically, this is like this guy. He's got these symptoms. Okay, he's got some signs and symptoms of like, or some not great stuff. He's got type 2 diabetes. He's got hypertension. And his really high blood pressure. And then he's got anemia. He's got asterixis, so that flopping tremor. So this is how they'll describe asterix. I tried to do it. I couldn't really show it. But you outstretch the hands, and then it's basically like they start flapping. So that's called asterixis. And then potassium's high, phosphorus is high, and then BUN is high. And they're like, okay, what's causing that elevated BUN? This is your classic chronic kidney disease. And remember, the reason why everything stays elevated is because you have a decreased GFR. So those nitrogenous wastes kind of like go into the blood. Okay, so this is kind of what he's saying. Okay, he's got fatigue, weakness, conjunctival pallor, which is anemia. Remember, EPO. Decreased EPO leads to anemia, asterixis, hyperkalemia, hyperphosphatemia, history of diabetes, and hypertension. This suggests chronic kidney disease. This is why I put this question on here. This is like a classic like signs of chronic kidney disease question. And then I wanted to Amboss kind of give, is this CKD or ESRD? Good question. So is this CKD or end-stage renal disease? I would say to know for sure if it's end-stage renal disease, you really need to know what the GFR is, because end-stage renal disease is exactly how it sounds. It's like you're at the end, like the kid, like you are not doing too hot. It's because of chronic kidney disease, but I feel like I would really need to see what the GFR is to know for sure if this is like end stage, like if this is like just not doing well. But for now, I would at least say that this is at the very least, chronic kidney disease. That's why we see because again, chronic kidney disease, you need time for the uremia to cause all these things, the asterixis, the decreased EPO, all that stuff. But that's a good question. I'm not 100% sure. This is just like a fun thing you can look at. It has everything that we've talked about. You just you can visually look at it now. And then I went through them. I took a screenshot of Mad Hunter and checked off everything in the prompt that led to mad hunger. So high potassium, uremia, and then EPO deficiency is everything they talked about in the question stem. Okay, yeah. All right, so I'm gonna go through this one. A lot of you guys have already answered. You guys are cardiologists. Everyone got this one right. I'm so proud. So this is Sydenham's chorea. Hopefully you recognize at least the milkmaid's grip thing. But this is that. So increased risk for which of the following complications? Mitral regurg. So remember Sydenham's chorea. This is your S in Jones criteria. So this is probably like a whatchamacallit, a acute rheumatic fever. And they talked about this. We went through this already. And remember, this would be the one. They could even ask this question, be like, what's the causative agent here? And then give you that list of microbes again. This would be your Streptococcus pyogenes, your group A strep. Okay. Good. So no questions with that one. Okay. More microbes. Down to G this time. Oops. Don't get got. Don't do it. I hope you hear me in your exam when you guys are taking your exams. Ah, don't get got. All right, I'm gonna go through this one. I think you guys all got it. Amazing. None of you guys got got. I'm really sad. I wanted one of you guys to get got so you wouldn't get got in the exam. But so this is obviously UTI, and they give you a bunch of stuff that is like, okay, it could be one of the ones to get you got. So we got a 28-year-old female. She had gonorrhea at the past, so gonococcal urethritis. She had gonorrhea basically. So she moved in with her husband, and she's sexually active. I'm telling you, whenever you see this, be so, like, literally so suspicious of it. Be like, okay, but like, I'm gonna keep going and like keep like looking at it. And then, so clearly, this is a UTI. This is exactly how a UTI presents. And they're telling you too now, look for nitrites, because if you want to rule out gonococcal UTIs, remember gonococcus, like Neisseria, gonorrhea, does not gram stain that well when you're doing it in the urine stuff. So it's going to look negative. So it's going to look like sterile pyuria. So this is both saying there's nitrites and bacteria. So you're like, that is not sterile. Bye. Where's gonorrhea? Bye gonorrhea. Bye chlamydia. Like these are out. Sexually active. You're like, what did I tell you? Don't just immediately sexually active and pick Staph saprophyticus. None of you guys did. I'm very proud. This is still E. coli. E. coli is still the most common cause overall. I don't care that it says she's sexually active. Okay. And this is like, the top two I put here. I was hoping someone would get got because I did want someone to pick this one. And this is what it says too, like in sexually active young women, staph sap is the second most common cause. I'm telling you, they have to like almost give you extra info for you to pick staph sap. You can't just immediately pick it. It's because E. coli is still the most common one. And they also, something interesting is they actually say, and they mention like a honeymoon in here, I think. Oh yeah. So she moved in with her newlywed. They actually say if you have a UTI from E. coli after getting married, they call it honeymoon cystitis. I think that's hilarious. And so, yeah, so just look for that in the prompt as well. Okay, two quick ones, I promise. One of these days you'll believe me. I'll finish on time one of these days. Have you guys like 10 more seconds? Yeah, go with your gut. All right, so this one in here So they're saying he's got tenderness above the left posterior calcaneus, the heel. This is another way of saying that he's got pain in his Achilles tendon. They will never say pain in Achilles tendon. They'll say above the left or right posterior calcaneus. And there's this skin colored nodule that moves with the Achilles tendon. This is your classic tendinous xanthoma, okay? So it's on the, like I said, I bolded Achilles tendon on that slide because if you have you have something in the Achilles tendon, this is going to be a xanthoma. Osler node. Oh, yeah. So good question. So like Osler nodes, I mean, I'm not saying they can't be in the Achilles tendon, but honestly, if they put like that it's an Achilles tendon, there's a nodule there, it's likely they're trying to get at a xanthonous, oh my God, a tendinous xanthoma. Yes, so Osler nodes are the tender one. Oh, does it say that on here? Well, you're right. So an Osler node is tender, but that's going to be for endocarditis. I know there's a lot of terms. There's a lot of terms here. But basically, for this one, they did a biopsy of it. And remember, I know it's really hard to see foam cells, but you can see cholesterol clefts. This should almost be like, you were like, oh, I didn't even read. I hope it's right. You don't even if you see this should just be like this is a cholesterol cleft. This is like a xanthoma. Like that's how knee jerking seeing this image should be and seeing these cholesterol clefts should be. So this is LDL. My triglyceride people. It's a classic answer. And again, that's why I did want you guys to pick triglycerides. Remember, elevated triglycerides is more so associated with pancreatitis. It really doesn't have anything to do with xanthomas. They're very similar. LDL and triglycerides, super similar. But the triglycerides, they have to say something about pancreatitis or something's wrong with the pancreas. All right. And then I have some pictures here. So your tendinous xanthomas, they can deposit like honestly anywhere, but the tendinous ones are going to be on the Achilles tendon. But you can have xanthomas elsewhere. And then this would be like another image of like, you can still see like I said, you can still see these elevated levels of that, but you really need to have the and this goes a little bit too much into the familial types, which is going to be covered in that video. I just more so wanted you to recognize the cholesterol clefts and be like, this is a xanthoma, this is LDL. It's because of LDL. All right, last question. And I put this on here because I really want to talk about something before your exam if you guys haven't covered it yet. So that's what this question is going to do. So reference ranges, sorry, I didn't give them for you. So creatinine normal reference range is 0.1 to 1. And then BUN is like I think it's like 8 to 20 or something, 10 to 20, I think. So basically elevated and elevated. I know. So yeah, so you guys called me out here. So normal anion gap, I call it 8 to 12 for sure. But my little note here, always use what they give you. Boards is going to be different from your exam, from Amboss, from UWorld, because they wrote the question, and don't be doing UWorld right now. I'm just saying, I'm giving you an example. They wrote the question based on the reference ranges they give you. Amboss, I looked at the labs that they provided. These were the reference ranges they provided for this stuff. So they even said it was 6 to 12. I always do 8 to 12 for anion gap, but again, use what they give you, okay? All right, let's go over this one. So this one, they tell you, patient has chronic kidney disease, so they tell you. And now start thinking of your mad hunger symptoms. So remember, mad hunger, it's going to be like metabolic acidosis. That's like the M and the A in mad hunger. So you can just, even with these, just straight up, okay, it's a metabolic acidosis. Look for a metabolic acidosis on here. So look for decreased bicarb causing a decreased pH. So this is not that, out. This is not that, out. This can be acidic. This can be it. And then 7.31 and 18. This can also be it, type of thing. I mean, I know it's not super acidic, but it can be. I know it's actually, you know what? No, it's no, I don't know. Because it's normal range, but it's like more, actually it's not more acidic. We're going to cross it out. All right. So it's out. So we only have A and E for this one. And then you have to remember chronic kidney, really honestly, the only way to do this one was to remember that chronic kidney disease gives you uremia. Very good. Mud piles. U in mud piles is uremia. And remember, mud piles, anion gap, metabolic acidosis. So you have to look for that elevated anion gap. Boom, A. Okay. So I think this is a very good question in terms of, like, again, tying in a bunch of different concepts for renal. So like it kind of said here, so this question, it's saying he's got end-stage renal disease. So I guess if it's like to the point where it's like, if you don't do dialysis and you like decompensate this quickly, that's like when chronic kidney disease turns into end-stage renal disease. But they are kind of like the same thing. It's just kind of like, you know, it's more of like a clinical question. Ugh, guys. But the one thing I wanted to talk about for this one, okay, is, bear with me, Winter's formula. I swear everyone gets confused on Winter's formula every year, and I want to talk about it very, very briefly as the last thing we do. So this is kind of like the whole thing. Remember, with anytime you have a metabolic acidosis, calculate anion gap. Once you calculate anion gap, it doesn't matter if you have a high anion gap metabolic acidosis or a normal anion gap metabolic acidosis. It does not matter. You do Winter's formula. Okay, so it should almost just be like a reflex. Metabolic acidosis, calculate anion gap. I calculate anion gap. I don't care what the answer is. I'm going to do Winter's formula. Winter's formula is basically like, how do I know? So for example, I know this is kind of second year E, but this is someone with chronic kidney disease who is oriented only to person. So you know how they say AAO times 3, like you're alert or oriented. I don't even know what it is, but like you're alert and aware of your surroundings. This man is not. He has progressively worsening confusion. Like this is his uremia causing encephalopathy. And again, this is, again, a very second year type thing, but encephalopathy can mess with your breathing. It can mess with your brainstem. You can start breathing weirdly. So I know he's compensating. That's like, he is compensating in this question. But how do I know it's not a mixed disorder? What if he's got a respiratory acidosis as well, and that's contributing to his pH? Or what if he's got a respiratory alkalosis, and that's contributing to his pH? Like maybe it's not a true like decreased pH because of the bicarb. It could be because he's holding on to some CO2. So you really, if you have a metabolic acidosis with just any metabolic acidosis, you have to make sure this patient doesn't have something else happening in the respiratory side that's contributing to his pH. So that's what you do with Winter's formula, and that's what he's kind of saying here. You have to use Winter's formula, okay? Oops. So with this, like I said, oh my God, metabolic acidosis, where'd my little pen go? Okay, metabolic acidosis, you calculate an anion gap. I don't care what it is. I want to make sure that this patient doesn't have a concomitant respiratory issue. So this you have to memorize is your, formula for Winter's formula. So this is what this patient's predicted CO2 should be. So and you can't do it in this question. That's what they're saying. Like you can't do it because we're predicting what the value should be. But if they give you his CO2, and they give you his bicarb, you don't even look at the CO2. You predict what it should be based on what his bicarb levels are. So basically it's like what I think this patient's CO2 should be is 1.5 times bicarb plus 8. And then you're going to get a number. Let's say you get 40. So this equals 40. When it's all said and done, this equals 40. Then you look at this patient's actual CO2, and his actual CO2 should be within 40 plus or minus 2. So if his actual CO2 is 38, you're good. If it's 42, you're good. If it's 39, if it's 41, if it's 40, you're good. So this answer, plus or minus 2, that's where it's like, okay, no mixed disorder. His metabolic acidosis is truly a metabolic acidosis. There's no concomitant respiratory acidosis or respiratory alkalosis. Does that make sense? So do winters. I really don't want you to get gout on your exam because you didn't do winters and you're like, oh my God, I don't know what it is. Because they will straight up have options where it's like, what is this patient's acid-base status? And some of them will just be like, metabolic acidosis with a concomitant respiratory alkalosis, metabolic acidosis, concomitant respiratory acidosis. And sometimes people are like, well, how do I know, like, if it's a concomitant one? Like what, like a concomitant acidosis, like respiratory acidosis or concomitant respiratory alkalosis? Look at what his actual CO2 is. If you're predicting his CO2 should be 40 and it's 31, that's like, okay, he's holding on to carbon dioxide. Like clearly he's holding on to carbon dioxide because it's dropping. No, did I say that wrong? Yeah, no, sorry. Because it's, so he's additionally, so yeah, I'm saying it, sorry, I'm confusing myself. He's holding on to carbon dioxide, which is probably further dropping his pH. So his true pH from this metabolic acidosis is probably also this mixed disorder. He's also probably having some carbon dioxide add to this problem as well. So he's probably holding on to it. So you kind of look at what like what the predicted value, like what the actual value is, and try and make sense of it with the question. I feel like first year they would only give you like one, like they would only give you like, oh, like one of the options is going to be mixed something, and that's if it's not 1.5 times bicarb plus 8 within plus or minus 2 of what they give you for carbon dioxide, just be like, all right, this is mixed. If that's the case, like whatever it says, just be like, this is a mixed disorder. Does that make sense? I couldn't let you guys go into this exam without going over winters. Okay, all right. I'm gonna stop sharing. Aw. I hope it helps. I hope you guys do super, super well. I'm gonna stop recording.